All right, so our first speaker is Dr. Giovanni Serenghi, who's going to be talking about high-resolution OCT. Where are we now?
Good evening. First of all, thank you again for the kind invitation. And, high-resolution OCTs, these are my disclosure, and the ones in red are the more relevant to this, my talk. So we actually, if you think about OCTs, the axial resolution, we move from 10 microns of the stratus and now to 2.73 micron with the new devices. The last two devices are not available right now, but are basically in research fields. And again, you increase the higher resolution, the axial resolution, but not the transversal resolution. For that, you need an adaptive optics or OCTs. And how that is obtained, instead of using a wavelength, and you use more wavelength, and that increase the full width half maximum with the device from MIT by Professor Fujimoto, and these are the ones from the MIT, and on the left now the one that I will show you with some images first tonight. And of course, if you think about, if you increase the resolution, you can actually see much better the difference between the lines. And in fact, these are the images from the Professor Fujimoto group, and you see that the resolution is quite impressive comparing with the histology. I want to underline two things here in these images. Usually we use a log scale that allows us to have a more defined images, more contrast, but if we want to measure, we have to use the linear scale, and unfortunately, we don't have in our devices, commercial available devices. And of course, as I said, because of the fact that you increase the axial resolution, we start to see more lines. And this is a paper by Christine Curcio with the prototype from Heidelberg, and that you see that now we are measuring 28 different lines, and now the most difficult things would be to find the names for each one. That would be, to remember, would be quite complicated. So we have the spectralis, the high resolution OCTs, the device that was, I told you, it's about 3 microns axial resolution. And now there is a new one that is probably will be available in commercially available in next year, and it's getting to a smaller resolution. So it's we move from 3 microns to less than 2 microns. And the question is this important for the clinical use? And I will try to show some example. Again, this was the lines that you can actually get from a 5 microns resolution, from the 3 microns, and again from the 2 microns. And you see that you see even more lines, and it's equal I will show you some example that the ultra high resolution is similar to the visual light OCTs that goes to 1 micron, and then it's actually probably important, not for the eye by itself, but for probably the oculomics in looking at some disease, systemic disease, looking through the retina. And here just one example of the image, and you can actually see all the layer. In particular, you define very well the choriocapillary, the Brooks membrane, the RPE, that are not anymore one single line, but you can actually differentiate. And you see that also the EZ, the ELM, and IZ is also very well visible also in pathology. We can actually see also the vitreous quite well, and you see that the liminal membrane can actually be divided in 2 lines, and if we move to the vitreous, you can actually see quite well also the vitreous, and something that we don't see so well. Another example of one patient with, and comparing with the autofluorescence, is quite interesting to see that you can actually identifying the black area and the autofluorescent area, and you see that the lack of RPE in the black area comparing with the autofluorescent area where, retina is not there, photoreceptor not there, but you can actually really well differentiate and understand much better the autofluorescent image. And the other advantage of the new devices is that you can actually also the flow in the B-scan for each B-scan, so you can really, for example, identifying the retinal vessels and comparing with hyperreflective foci to see if our vessels or are not, or are really hyperreflective foci, considering like activating microglia or other other exudates or whatever. The other interesting thing is the visualization of basal laminar deposits or basal linear deposits. That is not clear what we actually see in reality, but the possibility to define the basal laminar deposits is quite important because, as suggested by Shirley Sachs many years ago, these are the first sign of AMD. And so if we approach the disease very early, it will be quite important to have a possibility to identifying such deposits. And why now it's possible, and also it's possible to measure, because if you look at the measurement of the basal laminar thickness, you see that in a normal subject you have around 0.3 microns, and move to 4 microns, but if you have a resolution of 7, it's quite impossible to differentiate. So that this is why I think in that case it's important. And again, you can actually identify very well the choriocapillary and all the retinal vessels, but you also see the ELM that is actually divided in 2 lines. It's not clear why we can actually see such a thing. In this paper by Nadia Vaid and Professor Fujimoto group, they already describe. But there is also another interesting things on IPL, and you see the visible light OCTs and the ASRS spectral domain, and you can actually see in a very well that we can differentiate the IPL in a different layer. And just to let you know, if you look at the histology, you can actually understand where is the bipolar cells on and off. And this seems that it's quite correlated to, for example, with some schizophrenia. It seems that has some changes at that level, so it would be interesting also exactly for using in oculomics such a layer that usually we are not able to differentiate. What about the retinal vessels? Retinal vessels are very well been seen, and if you look, for example, the two veins that are branches are putting together, and if you look, you can actually see the flow of the 2 veins that are merging in a bigger one. But also you can actually identify in the wall and the fluid and so on, and that it's even better than not the adaptive optics images, but it's, of course, is showing the same, but it's a little bit more complicated than not taking with just a B-scan. And this is important because it's already shown, for example, in the Carrelese's plaque, where you can really see the differences in the thickness or splitting of the wall that can actually be solved with the treatment. And for example, another easy example of the fluorescein angiography comparing with the OCTs, where you see the leakage that is reduced in this vasculitis after the treatment. Or you can actually see also the same things on the choroidal vessels, and that's probably better visualization of the choroid and the choroidal flow can be probably related to the fact that, as I show, the wavelength is a little bit longer, so you can penetrate more, even if it's a spectral domain. And of course, for the same reason that I said for the BLD, also the size of the vessels can be identified much better. And so we can actually identify the wall vessel thickness in more precise, and that could be also useful if you think for detecting in some diseases, for example, hypertension. This was just published a paper on the choroidal flow, because you can actually see the flow in the vessels. So in conclusion, I think high-resolution OCT is a promising device. Of course, the possibility to see more details can actually open new possibilities, particularly, I would say, for oculomics. Probably not useful to detect the fluid in AMD, and if you want to follow to treat or not to treat. But for the early changes, I think it will be probably very important. Thank you.
Thank you so much. We'll ask any questions during the Q&A. Our next speaker is Dr. David Saraf, who will be giving 2 talks. The first talk will be Type 4 Macular Neovascularization, a new addition to the OCT classification of neovascular AMD, followed by a talk on pentosan maculopathy and coalopathy.
Thank you, Danny. Yes, so there'll be a little bit of a pivot as we move to the second talk. The first one will be related mostly to neovascularization in the setting of AMD, but we'll also talk about type 4 neovascularization in diabetics. These are both related to 2 papers we just published in Retina. But I wanted to give you a little bit of a background of how we arrived at this OCT scaling system that eventually allowed us to describe type 4. And I also want to acknowledge our fellows who helped with these 2 projects. So you may be aware from the 90s, the original classification of neovascularization in the setting of AMD was a histopathological one, or a pathoanatomical one, established by Don Gass. And at that time, they were able to understand that there were 2 forms of neovascularization, the most common underneath the RPE leading to pigment epithelial detachments, and then a second less common type in the AMD population, type 2, also originating from the choroid but breaking through into the subretinal space. And you could see this histopathologically, as I mentioned, type 1 under the RPE causing a PED, and type 2 breaking through into the subretinal space. This correlated with the classic well-defined neovascular subtype that was described at that time with fluorescein angiography. But with the advent of depth-resolved imaging, we were able to establish a third component of the neovascular form of AMD that was referred to before OCT as RAP lesions, and Bailey-Freund referred to this as type 3 because the predominant location was in the retina. And at that time, they still didn't understand if these lesions were originating from the choroid or originating from the retina. Later with OCTA, as I'll show you, these lesions were shown to be originating indeed from the retina, from the deep capillary plexus. And the type 3 intraretinal form that we refer to as RAP is actually a very common component of neovascular AMD that you can appreciate in almost a third of your patients. And with OCTA, as I mentioned, we were able to refine these gradings. Here is the most common form of neovascularization in AMD, where you can see this kind of stippled ooze under a pigment epithelial detachment. Here's the neovascular membrane that localizes to the sub-RPE component. After anti-VEGF therapy, you can see collapse of the PED. And the less common type is this classic type on fluorescein angiography. This localizes to the subretinal space with OCT angiography, and it has a worse prognosis because these patients often progress very rapidly to a fibrotic disciform scar in the subretinal space. The third version on OCT, as I mentioned to you, the RAP version or type 3, often will begin with a pigment epithelial detachment and what we refer to as this steer sign, which is really origin of the neovascular membrane from the deep retinal capillary plexus. And you can actually see the different stages in the development of RAP lesions or this type 3 version. We staged that in this particular publication. The lesions initially start as hyperreflective foci. Then you see an angioma in the intraretinal space that grows down to the RPE and then insinuates or grows into the RPE, leaks, and then can cause even a very large pigment epithelial detachment. And here's just a time-lapse video that shows you the evolution of these intraretinal neovascular membranes, or RAP lesions, type 3 MNV, originating in the deep plexus, growing down into the RPE, and then leaking into the sub-RPE component, and then associated with a PED and predominantly intraretinal neovascularization. And this is the still slide that shows you the evolution of that case of a RAP lesion. With the advent of OCTA, we were able to appreciate that these RAP lesions do indeed originate from the deep capillary plexus. When you segment at the level of the middle retina or at the level of the deep retinal capillary plexus, you can capture these intraretinal neovascular membranes or these RAP lesions very readily. And here's an example of one of those cases. You can see the flow, the signal of flow originating from the deep plexus into the RPE and causing this large serous detachment, even though this is an intraretinal neovascular membrane. And then after anti-VEGF therapy, you can see resolution of the RAP lesion or the type 3 MNV and collapse of the PED, and often resolution of the fluid, sometimes even just with one injection. After that original OCT classification, Bailey-Freud then published this very not well-known case report where he looked at diabetics with neovascularization and characterized the neovascularization that was developing neovascularization elsewhere along the surface of the retina. And because these lesions were on the surface of the retina, it was the natural progression from type 3 to what he called type 4 neovascularization. So sub-RPE, subretinal, intraretinal, and then pre-retinal in diabetics that he referred to as type 4. And it was this paper that we used to characterize what I'm now going to talk to you about, type 4 neovascularization in AMD. And I want to thank Hyok and Alessandro. They were the first two authors that really drove this study forward and were able to complete the study with publication in Retina just a few months ago. And what we were able to identify in about a dozen of our neovascular AMD patients was this particular form of neovascularization that was associated with this fibrotic membrane that was growing into the subcortical space that was previously referred to as central posterior hyaloidal fibrosis. And you can see evidence of this central posterior hyaloid fibrosis in all of these cases. But when they initially described this CPHF, they didn't have the benefit of OCTA to see what the origin of it was. And what we were able to do was identify several of these patients, of our patients with AMD who had central posterior hyaloidal fibrosis, but also we were able to do OCTA. And what we were able to identify in these patients was that there was actually choroidal neovascularization originating under the RPE, growing into the subretinal space, into the intraretinal space, and then communicating with the subcortical hyaloid through the central posterior hyaloidal fibrosis. And you can see evidence of this with the OCTA, choroidal neovascularization in the subretinal compartment, what we refer to as type 2, and then intraretinal neovascularization, and then growing all the way up into the hyaloidal space. And these patients had particularly poor prognosis with these disciform scars that evolved very quickly, and often had poor vision even on presentation with being treatment naive. Here's another example. The FA is actually very cool because you can see the type 1 neovascular membrane here in the choroid under the RPE, the classic type 2, then this intraretinal neovascularization here, and then if you do OCTA, you can see communication all the way up into the hyaloidal space. So these are type 4 lesions because they're communicating with the inner retina, but they're actually originating from the choroid. And because the predominant location was inner retina, we referred to them as type 4 lesions, similar to the case report that Bailey-Freund described in diabetics. Here's another example. Again, you can see this classic membrane here on the angiogram and on the OCT. It evolves to this area of intraretinal fibrosis. You can see all 4 levels of neovascularization from the choroid all the way up into the cortical space, and you can see flow going all the way up through the retina. This is another case, starting out as a type 2 classic lesion with presumably a type 1 lesion in the choroid. It evolves again to this area of intraretinal neovascularization that goes all the way up through this area of central posterior hyaloid fibrosis into the cortical space. Here's another natural history case, again starting as a combined type 1 lesion in the choroid, type 2, this classic lacy membrane, and then there is intraretinal proliferation, and then the development of this area of central posterior hyaloidal fibrosis with proliferation into the cortical space. And one final example showing the classic phenotype of this lesion. What's interesting, after we published these initial 10 or 12 cases in AMD, a couple of colleagues from Egypt identified these lesions in diabetics as well. So in patients with proliferative diabetes and severe non-proliferative diabetic retinopathy, several of them with hard exudates that can eventually lead to scars, we were able to identify these neovascular membranes with central posterior hyaloid fibrosis, and then this flow all the way up into the cortical hyaloid. And you can see beautiful examples of this. This was just published. It's in press. It should be released in the next few days. And you can see the area of flow going all the way from the choroid, the subretinal, intraretinal, and then into the cortical space via this central area of posterior hyaloid fibrosis. And another case illustrating the classic phenotype with identification of the neovascularization at all 4 levels. So in summary, I want to bring your attention to the OCT classification of neovascular AMD. It really is now the gold standard for the grading of neovascular membranes, especially in the setting of AMD. Recognize that the most common version is type 1 under the RPE leading to PEDs, but originating from the choroid. A less common one in the older patients are these subretinal membranes that are the classic version on fluorescein angiogram. You can also have neovascular membranes originating from the retina with predominantly intraretinal exudation. And now we've identified this 4th version that has a particularly poor prognosis that does originate from the choroid but grows through the retina into the subcortical space. And that's it for that talk. Thank you.
Thank you.
Should I go straight on to the Pentosan? All right,
Yeah,
so we'll
that'd be great.
completely shift gears and talk about toxicity to give you a sufficient breadth of information. And retinal toxicity is another area that we have great interest in at UCLA. And in particular, we have done a lot of work in the area of pentosan polysulfate toxicity, or what is referred to as Elmeron. I know they use this drug here in Canada as well. We published some papers in Canada too on this subject. And Elmeron, or pentosan polysulfate, is a very commonly used drug that lines the bladder epithelium to protect the bladder against contractility and pain originating from interstitial cystitis, which is a real disease. And the drug does definitely benefit the patients, but it's very toxic to epithelial linings. And these patients have significant bladder pain and contractility and urgency, and this drug seems to be very helpful in reducing those disconcerting symptoms. But the group in Atlanta at Emory, under the leadership of Niraj Jain, were the first to identify this speckled pattern of toxicity that can develop in the macula centered around the fovea, and in more severe cases centered around the disc. It was for many years confused as a form of macular degeneration or macular dystrophy, and it's really, I think, a great effort by Niraj Jain and his team to uncover this needle in the haystack, if you will. We were able to take the baton from the group in Atlanta, and we were the first to publish prospective screening of this drug. And in fact, we surveyed our database of 1,000 patients at UCLA, and prospectively we brought in over 150 patients who were on this drug at different dosages to really verify if this is a form of toxicity and if it is caused by the drug. And these were published in a series of different papers that I can talk to you about before I get to the colopathy. And this was one of the first papers we published in the American Journal. This was the first 100 patients that we screened, and you could see that there was about a 15% rate of toxicity that was related to the duration and daily dosage, and especially to the cumulative dosage. You can see the patients without toxicity had a cumulative dosage of 700 versus those with toxicity over 3,000. And here was the original series of patients that we had with toxicity. I believe this was the first 16 patients, it looks like, out of the 100 that we screened. And you can see this progression in the severity of toxicity that goes all the way from this stippled, speckled pattern to these areas of atrophy and even significant central GA in the patients on the highest dosages. Then in the final paper, we actually screened over 150 of our patients from UCLA, and we confirmed our original findings. And we also found some other interesting aspects that I'd like to share with you. And you can see here again the association with the duration of the drug, and especially the cumulative dosage, which was very significant. And here are the final 24 patients that followed that same pattern of severity that I showed you in the original AJO publication. And this seems to be, I think, a relative reliable prevalence, 15% rate of toxicity, which is significant. But this rate of toxicity grows to almost 50% in patients who are exposed to a cumulative dosage of 1,500 grams or more. So this is a very toxic drug, and the findings that you'll see on autofluorescence and OCT are very reliably identified. And here are the patients, and we actually created a grading system of these patients. This is a patient with mild disease, and you can see the classic speckled changes on autofluorescence centered symmetrically around the fovea. In patients with moderate disease, you can see areas of atrophy and C-RORA, or complete RPE, and outer retinal atrophy corresponding on the corresponding OCT, corresponding to these areas of hypoautofluorescence. And more rarely, in the patients who get up to the 3,000 cumulative dosage, you'll see central geographic atrophy and central C-RORA. And this correlates with the cumulative dosage. But in this final cohort, what we were able to also identify that was, I should, before I get to that, also mention that this is a relentlessly progressive disease, that once you stop the drug, you'll see expansion of the speckle changes towards the arcade and into the nasal periphery. And we believe that this may be from choroidal impairment, which we were able to show with OCTA may be the earliest sign of disease. And here's another example of a case Anamika put together for me, our fellow from Moorfields, and you can see that relentless progression towards the arcades and into the nasal periphery in this patient who had discontinued the drug several years prior, and in the left eye as well. But what we also found in this interesting paper that we published in Survey was that there was a significant signal of inflammatory bowel disease in our patients. 33% in the ones who had maculopathy and only 5% without. And we thought that maybe that was a high-risk factor for the development of the maculopathy, but what we subsequently were able to determine is that the drug is actually toxic to the colon, the colonic epithelium, as it is to the RPE and choroid. And in a final study that we just published in AJO, we were able to identify close to a dozen patients who not just had inflammatory bowel disease, but many who had been screened with colonoscopy and found to have severe polyposis, and were even genetically screened for Gardner's syndrome and adenomatous and the adenomatous polyposis gene. And this is an example of one of those patients who had the characteristic retinal toxicity with the speckled pattern. She also had these peculiar areas of pigment proliferation, but on colonoscopy she had these numerous large polyps, and several of our patients on Pentosan have actually undergone total colectomy because of severe polyposis and adenomatous dysplasia. And these were some of the other cases that we also published showing the maculopathy and these areas of polyps that we were able to track down in the chart with histopathological confirmation. Several of our patients with severe polyposis and adenomatous dysplasia, and another example of that severe polyposis in another patient in whom we were able to capture the colonoscopy photography. And so we recommended in this AJO paper that patients on pentosan polysulfate, in addition to the baseline and annual retinal screening, should also get colonoscopy, because we think this drug is severely damaging to the colon as well, and maybe even early on. So in summary, recognize that pentosan polysulfate is a drug with significant retinal and colonic complications. It has a 15% prevalence of retinal toxicity that is as high as 45% in those with a cumulative dosage in those with a cumulative dosage over 1,500, that prevalence rises to almost 50%. In addition to being toxic to the RPE and choroid, it is likely toxic to the bowel epithelium, and patients are at high risk of inflammatory bowel disease and polyposis, and that in addition to the multimodal retinal imaging with autofluorescence and OCT and NIR, we also recommend colonoscopy screening. Thank you very much for listening to two lectures.
Fantastic. Really great talk, David, Giovanni. So floor is open now for questions. I guess, Giovanni, my initial question to you, I mean, the images, we continue to see coming out of the high-resolution devices, I mean, they're spectacular. You start to feel like every time I see them, I learn something new. And one of the things I thought was really intriguing is when we've thought about an AMD, early signs of changes, wondered about some of the sort of reflectivity variability between the ellipsoid zone and the RPE, and it's almost too hard to measure on traditional spectral domain OCT, and I look at it on your images, and it's phenomenal. My question to you is, when SwepSource initially came out, there was a tremendous amount of hype and excitement around it, but yet we haven't seen that proliferation in clinical use. How do you see high resolution sort of penetrating into clinical care? Does it stay a predominant academic instrument? What are your thoughts on that?
Well, again, I think one of the advantages should be probably introducing OCTs for oculomics. Mm-hmm. And I really believe that will be a big advantage, because we can actually identify changes, particularly in the retinal vessel. I think retinal vessel, we actually just published another paper on hypertension, and there is a strong correlation between the changes in the retinal vessels and the organ disease, not only the hypertension, but you can actually differentiate the normal hypertension and hypertension with organ disease. And it's quite impressive because the possibility to differentiate such a small vessels and measure it correctly, I think it's very important. But recently, the visualization of IPL, as I show, it's also opening other, and I was speaking with my psychiatrist colleague, and are very, very interesting because identifying, for example, for schizophrenia, the possibility to identifying biomarker they are still searching, and having the possibility to look in the retina will be fantastic.
Yeah, it's amazing when we think about the way there's been so many papers looking at oculomics and everything from Alzheimer's, Parkinson's, cardiac disease, and a lot of times it feels black box because we can't really see what the different image interrogation is looking at. And yet you look at those images and you think maybe we would know what is actually there that might be being able to be picked up on spectral domain that we can't see. But now all of a sudden you look at it on high resolution and you could understand maybe what some of those.
Speaking about the SWAP source, I think, probably there will be also a changes in the SWAP source, introducing the high resolution also in SWAP source. So probably in the next years, we will see also the possibility to use the SWAP source for an higher resolution. Yeah. So it will be interesting. Yeah. Again, I don't think high resolution will be used every day for detecting the presence of fluid or not, but I think it's opening our job for more, in contact with all the other specialties, and but I think it will be quite interesting.
Absolutely. Other questions?
Any questions in the audience? Oh, please.
For Dr. Saraf, have you considered, David, doing genetic studies in these patients to see if there's a predisposition for developing the alterations that come with pentosal maculopathy?
Yeah, I mean, it would require, a targeted, genetic panel that you're looking at. Now, if you're just talking about the maculopathy and in terms of ruling out a macular dystrophy, those were done in the original studies, and we did those also in select patients from our group. I think it's relatively accepted now that this is a toxic drug manifestation, but in some of your patients, you do have to be careful to rule out pattern dystrophies and mitochondrial myopathies. Whether you're talking about something else systemically as to why these patients may be genetically prone to developing toxicity, that's another question that would require a different genetic screen. But certainly for these patients, this is a distinct entity, but you should be aware of masquerades like pattern dystrophy and mitochondrial syndromes.
May I suggest, I underline one thing. We see a lot of macular atrophy, and now that we have the treatment for geographic atrophies, it's important to differentiate. And so if you drag in the old macular atrophy, you start to see that probably most of them are not GA related to the age-related macular degeneration, but it's more related to other purposes, and that I think is quite important.
That's true. One of the ways to distinguish pentosan from AMD, because it can be difficult, especially if they present with atrophy, is that you don't see drusen in these patients. They get areas of RPE disruption and RPE thickening, but frank cuticular drusen or soft drusen or SDD, subretinal drusenoid deposits, they don't get those. So that can be a helpful differentiating feature.
And I think the FAF too, I use fundus autofluorescence less and less in for AMD, but for looking for those, mimickers, I think that's where it can be really critical. Danny, you had a question.
Yeah, I have a question, but I'll just echo on that comment. I think that's very important, especially for the fellows in the room. These days now with therapies for geographic atrophy, it's more important than ever to be able to distinguish AMD causes of GA versus non-AMD causes. Question for Dr. Saraf, when pentostin maculopathy was first talked about, I think there was some resistance from some of the urology community. Have you heard any feedback about your research from the gastroenterology community?
Yeah, I just got contacted by the head of surgery at UC Irvine who had a case of pentostin maculopathy in a patient who had massive polyposis. And this is just, on the heels of the article being published a few weeks ago. So I think the urology community is on board. Now we have to get the GI community to be aware of the potential implications.
David, two questions, one about first talk and one the second. So one of the things that, at least in a lot of the images for the type 4, it seems like the vast majority are foveal. Is that been your experience in terms of localization? Yeah,
that's exactly true. And what we think may be a key factor in the development is an attached hyaloid. So that's one reason you may not see it. Maybe these are younger patients with AMD. We didn't have a big enough cohort to really determine that. But having an attached hyaloid, maybe there may be some kind of inflammatory drive as well. That's why we think there may be a risk factor in diabetics. But that together, those may allow that neovascular complex that breaks through into the subretinal space, allow it to grow up into the cortical hyaloid.
Yeah,
so that's exactly correct.
And I wonder if there's also something just even about just the thinning. One other place I've seen it in diabetics is in post-laser CNV, where you wonder if there's some retinal atrophy over the top, and then you actually have
yes, that can be a factor too. I agree.
Well.
The cases that we just published in Retina in the diabetics, none of them were the result of laser in the macula, but that was an important consideration. And I'm sure we'll see cases like you've described.
Yeah, and then just more from a practical side, with Plaquenil, it's often a struggle of when do you stop the drug, especially in those select group of patients where it's clearly having an impact. A lot of patients, it feels like it doesn't. But there are some where it feels like a game changer, and we're questioning, is there a little bit of changes? Pentostin seems to be a little bit in a whole different category. The relentless, we know Plaquenil can continue to progress, but not usually at the levels that you're showing there. How do you handle when to stop?
Yeah.
Is it first anything on
I don't
FAF?
think, yeah, you're right. It's very different than Plaquenil. The changes with Plaquenil, as you and Catherine, you're world experts on this entity with Plaquenil at Cole. But pentosin's a completely a different animal. And as you mentioned, it's really not a question of whether we should stop the particular patient. I think the question's now becoming whether we should take the drug off the market entirely. I think it's that toxic. So certainly, if I see any evidence of a change in a pentosin patient, I will, very strongly advocate they stop the drug. But I'm wondering if the drug should be on the market at all.
Well, you know that in Europe and in Italy is not used so much. So
Which is a good thing. I think
yeah,
you guys are
exactly.
lucky.
So, but it means that you can actually, the urologist can use something different.
That's right. And there are other options, I think, to treating. It's a real disease. This is not a psychosomatic disease, but there are other options to treating this problem.
Yasha.
Just one question now. For those patients with extensive polyposis, do they progress to adenocarcinoma?
Yeah, that's a good question, Yasha. I don't know that we've seen any patient in our group get to that stage, but we have several who have had total colectomy.
Wow.
But that will become more of an issue, I think, down the line.
Wonderful. Thank you both for fantastic talks. My pleasure to introduce our next speakers, Sumit Sharma, who's going to talk about quantitative fundus autofluorescence.
Great. So switching gears a little bit. So I'm going to talk about, none of my financial disclosures are relevant. So the current state of FAF segmentation, and not just Stargardt disease, there are multiple diseases, is manual segmentation with some semi-quantitative additional features. And so, when we look at segmentation in Stargardt's disease, there's this definition of DDAF and QDAF, and these are defined as definitively decreased autofluorescence or questionably decreased. And the way this is done is a grader looks at an image and says, is the area of decreased autofluorescence greater than 90% of the total autofluorescence, and that's DDAF, or is it more than 50%, and between the 50 to 90% is the QDAF? This is a highly subjective measure. There is no thresholding to understand how it compares, but this is the kind of state of the art. There's also the Heidelberg Region Finder, which is a tool that was released in 2016, and this looks at adjacent areas of dark in the image and uses the grader can then adjust the area by scrolling up and down on the wheel to define how much of the area is actually marked as hypoautofluorescence. If we look at another tool, this was shown earlier this year. This is StarGauge. This uses predefined thresholds and looks at different graders using both manually, you can see on the right, 2 different graders, and in the automated tool. And it uses a threshold-based segmentation, so automating the methods that have been described in the past. But this threshold-based approach isn't enough, because as the brightness of the image changes, the ability to actually analyze and score and grade the area actually changes. And so we set out to actually define this in a prospective manner, and we built a prototype where we looked at manual segmentation in the middle compared to the platform-based segmentation, and found higher reproducibility in terms of dice scores for using this kind of initial prototype version that was also much faster for the graders, so about a 25% reduction in grading time, and gave you a higher reproducibility in between graders at measuring both DDAF and QDAF. And this came about because of a project where we're looking at our Stargardt's patients retrospectively and wanted to look at the fundus autofluorescence images and actually grade those, and weren't able to do it in any other manner versus manual segmentation. And so this led to developing this tool. As we were looking, there's a number of papers that have been published on this, of using machine learning to grade the segmentation, to actually segment out and grade the amount of both hypoautofluorescence as well as hyperautofluorescence that's seen in the red. And this paper looked at the ground truth is the first, the middle column, and that column shows you this is a grader going in manually and grading it. But when I look at these images, I think that we're missing a decent amount of granularity, and the AI algorithm that's trained on that ground truth does a pretty good job compared to the ground truth. But when you actually go in and look at it with our tool, you can see that there's a decent amount more granularity to that, and you can actually see that many more of these areas are segmented out, and this is based on the original tool that we showed at ARVO. When we look at this segmentation and we start to get into even more granular detail as you refine the tool, you can see that there's probably much more granularity to this, and how you define the areas of hypo and hyperautofluorescence change based on the overall brightness of the image. Comparing this to the Heidelberg Region Finder only does hypoautofluorescence. It doesn't look at ultra-wide field images. There's no vessel segmentation and no background indexing or references, and it only can detect lesions that have sharply defined borders with no reference-based thresholding. And so what we're doing is a little bit different. We're actually thresholding based to the overall brightness of the image, and able to define both this, what was originally defined as the DDAF and QDAF, but I'm going to propose that we name these a little bit different. And just as this tool, the OCT viewer, we can integrate with that and actually compare the areas of both decreased and increased autofluorescence to what the changes are occurring on OCT. And you can see in this patient with Stargardt's disease where they started at baseline and how they progress over time. And as I'll go in, because I'm going to define and say that what was previously defined as DDAF should be severe hypoautofluorescence versus QDAF should be moderate hypoautofluorescence. And where those thresholds are set, I don't think is well understood, because before you were doing this manually, and when you can do this in a quantitative manner, you were able to define what should count as moderate hypoautofluorescence and what should count as severe hypoautofluorescence in a much more granular manner. Similarly, looking at hyperautofluorescence should be defined in a couple of different manners as well. So either moderate or severe hyperautofluorescence, and that should help you better analyze both the lesions in Stargardt's disease as well as the perilesional hyperautofluorescence that we see in geographic atrophy and the areas of abnormal autofluorescence. And so I would propose that we should rename this, and this is going through the review process at a journal right now, and so hopefully this will be published soon. Just a few use cases as I finish up talking about different diseases. So this can be applied in ultra-wide field images from the Optos, and you can see perilesional areas in a patient with AMPI. We can see the significant amount of hypoautofluorescence with small areas of hyperautofluorescence that are nicely picked up and characterized. And there's a number of features that we're still working on, which is enhancing the segmentation detail, aligning images over time to give you better reproducibility in longitudinal evaluations, and then being able to do multimodal alignment, so taking FAF and OCT and really aligning them one-to-one and being able to show you what's happening on the OCT and how it correlates to the changes on FAF. But in something like geographic atrophy, where we're looking at an image on a Heidelberg device, being able to give you a very granular and very fine detail areas of hyper and hypoautofluorescence and the amount of hypo and hyperautofluorescence. And then this is a perception issue, right? So if you look at some of those areas, you say some of those areas next to that red area are dark. Well, why aren't we marking those as being dark? Well, it's interesting because when you actually go in and you look and you pixel peek and you look at the actual intensity, they're not that dark. It's our perception of the hyper around them that makes them appear dark. They're actually similar in terms of overall brightness to some of the other areas. So you begin to question some of the manual grading that's been done for GA in the past. How accurate was it, and can we do it in a better manner as we move forward? This is a patient with Stargardt's disease that's being looked at for longitudinal follow-up and how they're changing over time. And as we zoom in, we can see that area of both what was originally defined again as DDAF or the hypo-severe and the QDAF or the hypo-moderate increases over time significantly, and that the areas of hyper actually come down over time. Finally, the final case that I'm going to show is a patient with syphilis. You can see both pre and post treatment. So this is a patient who comes in initially, has a decent area of hyperautofluorescence that you're able to quantify the amount of hyperautofluorescence on that ultra wide field image, gets treated with penicillin. In the maps, you actually see the ellipsoid zone loss, and you can see what happens to the ellipsoid zone over time. So the pink is complete loss of the ellipsoid zone, blue is severely degraded, and you can see that the ellipsoid zone actually recovers over time in this patient, and we can see how the quantitative changes in autofluorescence occur over time, where that hyperautofluorescence actually goes down, and you start to see the areas of atrophy develop over time, and you can quantify these. And as we can quantify these over time, maybe we'll be able to better monitor treatment, not just in syphilis, but in multiple different diseases, including in geographic atrophy, as we talk about clinical trial grading and how we can better grade the areas of hyper and hypoautofluorescence in these patients. Thank you.
Introduce our next speaker, which is Catherine Talcott, who's going to be speaking to us about pseudodrusen. Kat?
Awesome. Thanks so much. Thank you to my colleagues for inviting me and to everyone for coming while we enjoy the nice clear weather in Montreal that is not in Ohio. So I'm going to be talking about pseudodrusen here, my disclosures. So I'm first just going to sort of give a little background about pseudodrusen in general and then talk about some work that we've done in collaboration with Justice's lab. So we're really lucky, I think, in the field of retina now to have some FDA-approved treatments for geographic atrophy, 2 agents, and these were, as we know, based on approval based on like reduction of GA lesion growth. But I think as practicing retina specialists, we're aware of some of the limitations of the therapies that currently exist on the market, and that these agents don't restore or reverse established atrophy. And so I think if we think about, our patients who we see with AMD, including geographic atrophy and those with earlier AMD in the intermediate AMD stage, it would be, I think, great to be able to have some treatment that we would be able to offer earlier in the disease, in the disease process before atrophy sets in, so more the intermediate AMD stage. And so I think this really brings to mind that there's some unmet needs in the field of sort of AMD and GA. We really need better imaging biomarkers that can identify sort of high-risk patients earlier in clinical practice, and those can inform sort of how we manage those patients potentially and how clinical trials are like designed, as well as identifying biomarkers that can reflect earlier outer retinal problems that are more closely linked to functional outcomes than are currently available. So as we know, there's a bunch of studies looking at sort of, in general, imaging risk factors for those patients who are going to go on to develop atrophy. This is a paper from Voss looking at OCT features for which patients were found to have increased risk of C-RORA at 24 months. And these are the things that sort of, we talk to our trainees about when we're in clinic, looking at sort of high central drusen volume, hyperreflective foci, hyperreflective drusen core, C-RORA in the other eye. But what I'm going to focus on really for today's talk is SCD, or subretinal drusenoid deposits. And this may affect sort of how we follow patients and then how we risk stratify them. So among these different biomarkers, SCD have really emerged as a distinctive phenotype in AMD. David mentioned a little bit earlier in the Q&A section a little bit. But high-resolution imaging and multimodal has really localized SCD, as they're named, sort of above the SCD. This is the classic paper that was published in 2010 looking at different sort of stages of what was termed to be SCD. And sort of at stage 2, you have deposits underneath the EZ, and then at stage 3, almost this canonical form that pops through the ellipsoid zone. So really distinguish these as a separate entity than sort of sub-RPE drusen. There have been a lot of studies looking at SCD and whether or not these are associated with an increased risk of progression to sort of late AMD. The AREDS study was examined, and so in the AREDS study, SCD presence was associated with a higher risk of AMD-like progression, but varied really depending on the baseline severity of the disease, and that's shown on sort of the left. And then there's other studies that have also found an association, including on the right by Dr. Finger, looking at 200 patients who had CNV in one eye, looked at the fellow eye, and pseudodrusen was associated with a shorter time to progression of geographic in that eye. So some of these cohorts have shown an association. There's also been papers looking at SCD being linked to functional markers as well. This is a paper looking at impaired dark adaptation and rod dysfunction. The metric that they looked at was rod intercept time, was the time for sensitivity to recover to a set stimulus, which was 3 log units. And in this study, they found that patients who had SCD actually had a greater mean rod intercept time compared to eyes without SCD, and as well as in any AMD-like severity group shown there. But sort of given these findings, the independent prognostic factor of SCD really remains up in the air. So other cohorts have looked at this, including AREDS2, and where a person-level analysis did not show that there was a significant association for SCD if you took into account the AMD severity levels. And other studies, as the one shown on the right, haven't found an association at all. So while SCD are really considered to be sort of markers or sort of higher risk, their consensus as an independent risk factor is really lacking. And so one of the ways that we thought to better analyze this is to look at AZ to RPE thickness. So as sort of has been often sort of presented, and Sumit's kind of alluded to with some of the images that he showed in his last talk, this method really allows us to be able to look at photoreceptor outer segment height and thickness, so looking at total EZ attenuation, which is an FDA approvable endpoint, as well as partial EZ attenuation. They may offer us some insight into earlier disease, as well as how SCD can be involved. And so this really allows us sort of the opportunity to sort of better analyze if there's sort of any EZ loss, and this can be, useful for dry AMD. So we sought to look at pseudodrusen or SCDs and the interplay between these and these EZ metrics that can be looked at, as well as sort of the contributions of SCD and EZ integrity to how AMD progresses. So to be able to do this, we looked at an analysis of 700 eyes with dry AMD. Over 500 of them had intermediate AMD, and almost 200 of them had geographic atrophy. These images were analyzed by 2 independent readers, looking at quantitative EZ integrity metrics. And these patients, and especially looking at if these patients had SCD, which was defined as 6 or more in the macular cube scan, to be able to better tell the association between EZ integrity measures with SCD, as well as that interplay and how disease progresses. So this is a cross-sectional comparison of these patients who had SCD versus not. And as you can see here, those patients that we looked at who had SCDs had greater EZ loss and more hyperreflective foci present. If we looked at this a little bit differently, if we looked at just the patients who had intermediate AMD, so taking out those geographic atrophy patients, we then looked at those patients who had stable intermediate AMD over the course of 2 years and those patients who went on to progress to have geographic atrophy. We actually showed that those patients who progressed had higher SCD prevalence, greater ellipsoid zone, and more hyperreflective foci at baseline. So to be able to better sort of understand the relationship with the two, we then looked at predictive models for like progression to be able to see how subretinal drusernite deposits as well as partial EZ attenuation sort of correlated. And we found that actually partial EZ attenuation was the strongest predictor for progression and was independently significant in a multivariate model, but SCD presence was not found to be significant in this multivariate model. So here's just an example of a patient. So this is kind of looking at baseline. You can see that they have pseudodrusen that are present on sort of the EZ. And if you look at the bottom in the bottom middle left, that EZ to RPE thickness, that where the pink and purple areas show EZ loss versus the GA map right next to it. You can see at month 6, there's progression of that EZ attenuation and starting to be some development of the geographic atrophy that correlates with the infrared image shown on the left. And you can see how really over the course of 24 and 30 months, 36 months, this patient unfortunately has a lot of atrophy that progresses. But if you go back and sort of look at the predictive patterns, you can see what the GA map ends up as. The EZ integrity map 24 months prior was actually quite predictive of it. So in conclusion, SCD are considered to be this marker for higher risk, but there's really consensus lacking if it's an independent risk factor. We can look at EZ attenuation, both partial and total, which are strongly linked to the progression of intermediate AMD independent of SCD. But in our analysis, we found that SCD were more frequent in intermediate AMD patients, but progression, but this association was really, unfortunately, attenuated after the integration of EZ metrics. So these are likely all sort of contributing together, but I think the strongest predictor for how patients do is EZ in integrity. Just wanted to say thank you.
Thank you so much, Kat. Our final speaker of this session, Justice Ehlers, a quantitative ultra-wide field fluorescein angiography and diabetic retinopathy.
Awesome. Thanks, Danny. And thanks, everyone, for being here. It's really great turnout. Hard to believe it's been 15 years that we've been doing this, and I think I might be the only one up here who has been here for all the 15 years, which tells you how old you are. So these are my financial disclosures. I'm going to stick with the theme of quantifying features in the images that we use for taking care of patients. You know, with diabetic eye disease, one of the real challenges is the heterogeneity that we see. You know, we rely so much on OCT, and this is a very common picture that we see of somebody coming in with macular edema. But the challenge for us is that this could be in patient A or it could be in patient B, and these are widely different disease patterns and how we might approach it and maybe what treatment we might want to use for this patient. And so there's clearly unmet needs. You know, angiography, potentially for macular degeneration, may be almost dead, you know, with OCT angiography, but I really think in the combination of both diabetic retinopathy, retinal vascular disease, and inflammatory eye disease, ultra-wide field angiography really still has a place. And we may be able to now use technology to better understand the phenotypes of the patients that are in front of us. So several years ago, Sunil Srivastava and Sumit and I started to wonder how could we actually quantify these angiograms to better understand the diseases that are in front of us, to be able to look at things like ischemia, leakage, microaneurysms. And what you're seeing here is actually just using traditional image processing patterns to try to quantify these features in a way that allowed us for the first time to really describe this in patients and understand disease process, ranging from microaneurysms to leakage as well as ischemia, and to better understand how these may inform us in terms of treatment response as well as overall prognosis. And when we looked at this, we wanted to develop better understandings of what we're actually describing and quantifying. And this included things like ischemic index, which was not originally described by our group, by others when ultra-wide field angiography first came out. And that's really essentially the percentage of the analyzable area that shows ischemia. Similarly, you know, we can do the same for leakage index. What's the amount of the area of the tissue that's leaking, and then also a microaneurysm count. And what we found with this was that although the tool was actually, you know, reasonable performance, leveraging machine learning technology allows us to go to another level in terms of what we can actually look at. Instead of only looking maybe at a parameter, we can automatically detect the region of interest. We can evaluate the blood vessels, as well as taking out artifacts like the eyelids that are at the edge of some of the images that we do, and to be able to then even identify things like the optic nerve, the fovea, and be able to use this at essentially an automated level at a whole different way and scale that we can do than just with traditional image processing. So these are just some examples here for leakage detection. And again, at a phenotypic level, originally what we cared about is, can we quantify leakage? But then we started to realize that there's even phenotypic differences in the way leakage looks. Some of these, almost in diabetes, may look more like uveitis, where you have what looks like more of a vasculitic type picture, and can we actually quantify perivascular leakage rather than just total leakage in the eye, and that may have different prognosis values. Can we look at things like leakage velocity? How much does the leakage change over time? Angiograms are dynamic images, and being able to look at this may also help us understand how severe, how active a given eye is. One of the other things that machine learning really allows us to look at is the underlying vascular features. And using machine learning, we can actually pull out the vascular structure in ways that almost look like OCTA, and to be able to quantify everything from the amount of blood vessels that are there. But also when we look at abnormalities, we can see here the gaps that exist where there's no blood flow, or even the tangles that are there where we see actually retinal neovascularization. And the interplay between this may actually be critical in terms of being able to identify some of the subtle features in the diseases that we see. So when we first looked at this with our original platform, we did this in this natural history study to look at eyes with diabetic retinopathy from mild to moderate, severe, and PDR, and showed that each of these parameters were strongly linked with the underlying traditional way that we grade diabetic retinopathy severity. But interestingly, just because that's the way we graded it before doesn't mean it's the way we should actually grade it in the future. And in fact, particularly in the middle, in like the moderate diabetic retinopathy and the severe diabetic retinopathy, there's some eyes that they just stay that way long term. And there's other eyes that progress really, really fast. And there's some suggestion that maybe some of these angiographic features may be perhaps the most critical in understanding sort of these phenotypic variations that are there. These are some examples of what we might see in terms of from mild, moderate, severe, and PDR. And now you can start to think through and looking at clinical trials and all of these new pathway drugs that we have, we may be able to actually understand more and more what we're seeing than just two-step progression or two-step improvement in diabetic retinopathy severity. Here we see leakage as well, mild with very minimal leakage all the way up to very severe leakage in these proliferative diabetic retinopathy eyes. Ischemic index as well, and this was all strongly linked in this original study that we did, which was encouraging that we were actually looking at something that mattered and was consistent with the biology that we were seeing in the patients that were in front of us. One of the opportunities that we had was actually to work with DRCR to look at protocol AA. You know, historically, one of the biggest gaps that we had is that not enough places in clinical trials had the devices. And unfortunately, in the early trials looking at diabetic retinopathy, the most critical piece for the companies that were developing the drugs was really to understand the key primary and secondary endpoints. Were they working, and not necessarily the exploratory nature of insisting that you have an Optos or another ultra-wide field system. Now we're seeing that the prevalence of those devices is much, much higher. And so we're going to see, I think, a much greater opportunity to understand this at the clinical trial level. Protocol AA was really the largest scale ultra-wide field assessment looking at the observational changes in diabetic retinopathy in eyes that don't have center involving DME. This looked at this over the course of 4 years. They got an angiogram at baseline at 1 year and then at year 4. And the initial interest at the AA level was actually looking at fundus photos. And what they found was originally that there wasn't much difference between the peripheral lesions that were seen on that. But interestingly, when they looked at lesions on angiography, that was significant for progression. And they had predetermined that they were going to look at non-perfusion, and we can see here this relatively good correlation between mild NPDR all the way up to PDR, but again, a little bit of noise and oscillation there, and this was also linked to progression risk. But we were able to partner with DRCR and actually analyze the leakage aspects and looking at this regionally as well as across the entire retina. And what we found, and we were masked when we were doing this, we didn't have access to the fundus photos, so we were only actually analyzing the angiograms, a very clear stepwise association between leakage and underlying diabetic retinopathy severity, but then also to some of the key features that we care about. Diabetic macular edema presence was very clearly different in those eyes that had a higher amount of posterior pole as well as macular leakage. And so at baseline, there were some things that clearly popped out. Interestingly, things that are really critical, things like poor visual acuity was linked to higher leakage. And one of the things when we look at endpoints that the FDA might be willing to look at, it's about does it matter to the patient? And so seeing some of these functional links were really important as well. We also wanted to look at longitudinally what happened to these patients. And one of the things that we found was actually leakage was probably the most important factor, more than non-perfusion, in eyes that went on to worsen in terms of their diabetic retinopathy disease status. And if you look at the risk for vitreous hemorrhage, it's really the highest quartile and is way higher. You look at this 28% risk compared to only a 3% risk in the first quartile. So for me, what this informed is if there's not much leakage on the angiogram, the risk to these eyes is actually relatively small of a progression over time. And so this is really informed as we look at, how do we risk stratify patients for trials who are going to go on to potentially develop complications. You really don't want to be putting patients in those trials that don't have much leakage at baseline. So can these be used in a clinical trial setting? And we've seen this now in multiple different trials where we've used this. This is an eye at baseline. This is one of our first ISTs to look at whether we could actually do this from a quantitative standpoint. This is at baseline. This is at month 6. And you love to say, wow, that didn't just get a lot better. You'd like to be able to quantify that. And in fact, when we looked at this, you could see that the microaneurysms were improving, something that it wasn't really well established before. But now you could actually look at this and say this patient went from 354 at baseline to 65 after treatment. Similarly, a dramatic reduction in leakage that we know when we see this with anti-VEGF therapy, but now we can quantify it. And similarly, ischemia, what we found with anti-VEGF therapy was maybe there's a minimal improvement that's relatively inconsistent across patients, but we're not really seeing clear improvements over time there. One of the areas we can look at this is in novel therapeutic assessments, and we did this with a phase 1 Helios clinical trial looking at one of the OTX-TKI drugs and trials here. And what this trial looked at was a single injection at baseline, and then looking over the course of 1 year what happens with diabetic retinopathy compared to sham. And what we found with this that was interesting was that there was a sustained reduction in leakage that was maintained throughout 1 year with a single injection of OTX-TKI. And again, I think when we look at this, it's compelling in terms of what we want to see, particularly in diabetic retinopathy where we're not actively treating that with anti-VEGF therapy. We want a drug that's going to last. And the angiography was really, again, impressive in these eyes. And then how do you go on to monitor these patients as well? One of the other questions, can we use these treatment thresholds? And this was a trial that we did with Charlie Wyckoff's team down in Houston, where we actually used leakage index to decide are we treating a patient or are we not, instead of using diabetic retinopathy severity. What we found was when we used leakage index, we were actually treating earlier on and as a more leading indicator, and found a little bit more improvement overall in DRSS, but could use a more customized approach to this in the way that we look at this. And then the last thing is, can we actually use this to underlying the driving pathologic mechanisms? And for me, when we think about what we really want to move towards in retina as we have more and more drugs available is precision medicine. Right drug to right patient. How do we pick between the potentially 10 drugs we may have in 5 years in our hands? And when we look at leakage patterns, we were able to look at this with aqueous cytokine expression to say this is a high VEGF load eye versus a low VEGF load eye. And perhaps we can look at other pathways, such as looking at the Wnt pathway of overexpression there. And maybe, drug A may be a better choice than drug B for a given patient. So overall, in conclusion, image-driven management in diabetic eye disease is likely to continue to enhance the way that we take care of patients. For diabetic macular edema, obviously OCT is the anchor of what we use for that, but ultra-wide field angiography may really help inform how we look at diabetic retinopathy as well. And being able to compare this, if we can look at things like an angiographic severity scale, may be really important for us to sort of put away some of our traditional diabetic retinopathy severity scale based on fundus photos alone to better classify more on a continuous scale the way that we look at our patients. I want to acknowledge my team at the Cleveland Clinic, and again, thank you for your attention and being here tonight.
Amazing work. We are in such a cool area in our field right now where we can quantify, this amazing multimodal imaging we have access to. So just incredible work by Kat, Sumit, and Justice. I'm surrounded by brilliance here. We have a question from the audience to begin with here, actually.
Dr. Ehlers, it's a very interesting presentation. Curiously enough, now that we use more and more images and we see less and less patients directly, we have kind of discontinued the use of fluorescent angiography. Basically, Sunil is the only person that I've heard that
Yeah.
fluorescent angiography. But now you mentioned that this is the most important factor, And this is interesting because in the daily practice,
Yep.
it's difficult to assess without an angiography
Yep.
the leakage. And I have seen patients with severe ischemia, but still 20/20 vision and
Yeah.
no macular edema.
Yeah. So it's a real challenge, and I'm a believer, and I still struggle to order it. And it's tough in the level of the volumes of the patients that we see, deciding when to do that. And for me, I almost never get it the first time I see a patient because the impact in workflow is so significant. It's usually on follow-up. There's also the challenge of you really want to do it before you initiate treatment, because as soon as you introduce, at least currently, anti-VEGF therapy, you dramatically, change the signals that are there. Long term, my suspicion is that we will be able to infer leakage based on our other non-invasive imaging. If you look at some of the work that Sumit's and Sunil's team have done, and some of the work that we've been doing, and even looking at what Giovanni was showing on high-res OCT, you can see that there's actually fluid that exists around the vessels, even without frank macular edema. And so I think that with better and better analysis platforms, we'll be able to essentially pull out those leakage patterns. And there's also now AI platforms where you can take like the OCTA and recreate, the angiograms. I've seen some impressive things. Some of them look too good to be true, and they look like they're overfitting. But I think long term, it's likely. I think it's really critical that we understand leakage. I don't know that it has to be with fluorescein, but it's the only thing we have right now.
Any other questions in the audience, please?
Yeah, I think that's a great question, and I think why there's probably been so much mixed thought and mixed evidence as to whether or not like STD, like on their own, like can be a prognostic sign of like AMD, like progression. The OCT analysis system that we use can correlate, if the EZ is totally gone in an area, or if it's just if it has like less height than sort of normal. But by looking at sort of the multifactorial analysis, it actually looked like the bigger contributor is actually just EZ attenuation for those patients progressing instead of the STD. So I think the initial work for like STD was done looking at sort of localizing that and where they kind of seem to progress. But it seems to be more that ellipsoid zone attenuation is the bigger predictor, and probably STD presence is kind of a sign of that progression. But thank you for the question. I think that they overlap for sure in those areas, but the way that we sort of quantified it in the study was just having the presence of STD overall. STDs are, more commonly found in like some parts of the macula sort of than others, but for sure.
Can I make one comment on? Go ahead, Josh.
I was going to say, actually ask you guys, just like from a clinical observation, what you sort of see is the ellipsoid zone's fully intact and not attenuated over subretinal drusenoid deposits. But then as you move from stage 2 to stage 3, that's when you start really sort of seeing ellipsoid zone attenuation. And then effectively what happens is you end up like the subretinal drusenoid deposit, like kind of almost like sort of flattens, and the ellipsoid zone's kind of absent. So I wonder if one of the rationales for why you identify it to be a higher risk factor is because you're just identifying it in a later stage of disease progression. So I'd be kind of curious as to what your thoughts are on that, and if you've done longitudinal analysis to see where that ellipsoid zone is getting lost and how that correlates with subretinal drusenoid deposit burden.
Was that to me? Or
Oh,
to
anyone.
Kat?
Anyone.
It
Yeah,
sounds like
anyone.
you're going to say something.
Yeah, it's
Well, just to add to that and to follow up, one I want to credit our research fellow Masa Mizuno, who really did a ton of this work and came up with some of these really unique ideas. I mean, to your point, Yasha, when we look at this, I really think what we're seeing is the outer segment damage is what we're measuring as partial EZ attenuation with thinning. And so even before we see EZ loss, we're seeing some of the damage that exists in some of these eyes that have SDD. You look at it and it doesn't look like a healthy eye. And even though we don't get that more mature SDD that's going directly up through the EZ with EZ loss, one of the questions is we see so much phenotypic variation in AMD. And one of the ideas was that potentially we're identifying really two different pathways, one that's RPE driven and one that's photoreceptor driven. And perhaps, as was being said, the SDDs are an after effect of the outer segment damage that's occurred from photoreceptor dysfunction. And that's why we're measuring this earlier. And at least at the level when we looked at this, the EZ measures clearly outweighed SDDs. And it is sort of a funny thing because, as Kat said, we said if there's more than 5, they're present. And that's actually a pretty standard reading center across the board standard. And I think it's because they're so tough to grade with it. And we did actually go through, I don't know how they did it, but 3 of my research fellows went through and literally counted them. So we actually had them all the way up to, 150, it could be in one eye. And we didn't see as strong of a link with overall burden as just presence, absence when we looked at that.
I have a question for both Sumit and Justice. Same question. Maybe we can start with Sumit. These are amazing images you showed, quantifying FAF, quantifying fluorescein angiography. We have some very interested fellows that are interested in research. We have wonderful industry partners here. What are some of the steps and barriers to getting these things approved as FDA-approved endpoints?
I'm glad Sumit's going to answer this.
Yeah,
first.
I know.
I need to be careful. We should talk about this afterwards.
Yeah. So I think from the FDA standpoint, right, they've already accepted, at least in FAF, the change in GA lesion area as an endpoint. And how you actually do that quantification right now is a manual process. So changing it to an automated or a semi-automated process where you have oversight from a reading center still, I think would be acceptable to the FDA as a broad generalization. I don't want to speak for them, but I think as a broad generalization, that would be something that's acceptable. But what really needs to happen is we need integration into the device itself. And that is where you start to actually see more traction, where anyone can access it, anyone can use it. And the nice thing is a number of the device manufacturers have these new platforms that are launching imminently that allow individual researchers to develop a tool that others can then get access to. And so I think that is probably the next step that's necessary. How the licensing will work and who owns it and how you deal with that aspect of it is going to be a challenge. But I think at least for FAF, the pathway is a little bit clearer. For fluorescein angiography, I think it's a much more challenging process.
Yeah, and I think there's 2 sides to that discussion. One is approval of the measurement within the device, which actually has nothing to do with whether it has clinical value. It's just whether or not you can measure it consistently in a way that matters. Like CST, for example, is in all of our OCT machines, but it's never been allowed as an approvable endpoint for a clinical trial. But they were able to show they could consistently measure retinal thickness. And so it's about creating the investment, in doing a study to show you can measure it consistently. And the challenge is academic centers aren't generally set up to do that and don't take it all the way through the FDA, and that's why oftentimes you need in that case, it'd be more of a device partner. On the endpoint side for clinical trials, what the FDA has said, and we now have a new team that's there. Wiley Chambers was there for a very long time, and really what he anchored on was that no photoreceptors, no vision. And so if you could show that you're losing photoreceptors and the original sort of image-driven endpoint that was approved was actually based on CMV retinitis in fundus photos showing atrophy, and it was not based on atrophy. And actually the fundus autofluorescence wasn't based on atrophy of the RPE. It was because there was inferred photoreceptor loss over the top. And so it's all about, for them, does it matter to the patient? And photoreceptor loss was thought to, we'd have to show that leakage matters, whether for predicting future complications like TRDs, vitreous hemorrhage, and diabetes, or direct vision function issues as well.
Okay, we're going to get going while everyone else trickles in. For the next session, we're going to be kicked off by the wonderful Dr. Jasmine Francis. She's going to give us 2 talks. The first one is imaging characteristics to differentiate between benign and malignant tumors.
Good evening, everyone. I'm going to give this talk almost as a self-test. So I'm going to present you with some images. You're going to look at them, and in your head or on the paper in front of you, you can write down what you think the diagnosis is, and you can use general categories like, is this benign or is this malignant? So if we start with this first slide here, this is a choroidal hemangioma. Let's figure out why the imaging would allow us to determine it to be a hemangioma. On the autofluorescence, you can see it's a mixed pattern, but you can also see the extent of the subretinal fluid inferiorly. On the OCT, you see that there's expansion of the choroid, but not compression of it. And what's really helpful with a choroidal hemangioma are an ultrasound in which the intensity of the dome-shaped lesion is very similar to the choroid. So that's known as iso-intense with the choroid. And in addition to that, probably the single most useful imaging modality is indocyanine green, and making sure that you take this image all the way out to 15 minutes or beyond. So to show you that in a more expanded version, a choroidal hemangioma characteristically will be early hyper-autofluorescent, and it will have a very late washout and become hypofluorescent. Moving on to this middle image, this is a suprachoroidal hemorrhage, although was sent in for concerns that it could have been a melanocytic lesion. On the autofluorescence, it's very bland, no hyperautofluorescence. You can see on the ultrasound that it really spares the choroid if you track the choroid around the globe. And then what's the most useful here, if you can get it out into the periphery, is using the OCT. And let me see if I can show you. Yes. So here you can see retina, RPE, then you've got your choroid, and then obviously in the suprachoroidal space, you have the blood, and then there's your sclera. And also what's helpful with these patients is if you wait and you see them in follow-up, and it should go away if it's suprachoroidal hemorrhage. Now moving on to this last one here, this is a uveal melanoma. It's pretty classic for that. On the OCT, there's subretinal fluid. There's a mixed pattern on the autofluorescence with subretinal fluid. On the ultrasound, it's dome-shaped. It's got low reflectivity and acoustic hollowing, which basically means that this is got hollowing. And if you choose to do an FA, which we don't usually do with a melanoma, but it's good for talks, then it will show you a double circulation sign. So moving on to the next 3, here are 3 more melanocytic lesions. So in your head, be thinking what you think is benign and what's malignant. This first one is eccentric disciform, or PECAR. And on the autofluorescence, it's mainly hypo, but you can see some areas depending of hyper-autofluorescence. On the ultrasound, you can tell here that if you track the choroid around, that this is really in the retina. Because it's so peripheral, we do a UBM, which does not show any involvement of the ciliary body. And on ICG, it's largely quiet, but sometimes you can see these choroidal telangiectasias. Now this middle lesion, what do you think this could be? Again, this was sent in for concerns that it was a nevus or a melanoma. This turns out to be a chirpy on autofluorescence. It's very densely hypo, and it is flat on ultrasound, and on OCT there is overlying thinning of the retina. There is often thickening of the retinal pigment epithelium, except where you see a lacunae, and the choroid is usually thinner. And here is another example of that, again showing that the choroid is also thinner. And then finally here, hopefully you'll know this from the previous slide, this is another uveal melanoma. And to breeze through the reasons why we've got acoustic hollowing on the ultrasound. Again, we look at the UBM sparing the ciliary body, and there's the double circulation sign on the fluorescein. What about these amelanotic multifocal lesions? This first one was sent in for concerns that it was metastasis. It was bilateral, but these are scleral choroidal calcifications. It's pretty classic for that. They're hyper-autofluorescent. They are typically bilateral. They're along the arcades, typically the superior arcades, or around the insertion of the muscle. They are very highly reflective on ultrasound with an acoustic shadow that you can see there. And then on OCT, what's helpful is to see these kind of right angles. Calcium really likes to do right angles on OCT. And so seeing that is a good sign that this is probably a sclerochoroidal calcification. This middle one is, in fact, metastasis. The autofluorescents are really informative for metastasis. It can show you areas that you wouldn't otherwise think were involved. These are typically a bilateral process. I'm showing you this eye to demonstrate that the subretinal fluid is usually way out of proportion to the size of the lesions. These patients can complain of pain because the met can grow into the sclera and nudge on the long posterior ciliary nerve and give pain. You can see that this ultrasound shows that it's multi-lobed and has mixed reflectivity, as does the OCT. And then this last one is classic for vitreoretinal lymphoma. You may be able to tell in this image that it's a little bit vitelliform, that it is hyperreflective on the autofluorescence. And of course, it's vitreoretinal lymphoma, so you look for cells in the vitreous at slit lamp. And then what really defines it here is the fact that this material is beneath the RPE. And then this is after treatment with intravitreous injections of methotrexate and rituximab. What about these two lesions? Which one is benign, which is malignant? I'm not going to give it away quite so easily. On the autofluorescence, you can see that there's a mixed pattern. On the ultrasound, they're both hyperreflective. But do they look like a scleral choroidal calcification? Not really. And then on the ultrasound, you can see these lamellar findings within the lesion, which is within the choroid, and these overlying RPE disturbance. The top one is a choroidal osteoma. The bottom one is choroidal histiocytosis, which is very rare. Many of you may not have seen this and may not see this. Really difficult, in my opinion, to distinguish between these two, but perhaps the choroidal osteoma has more of these spicule shapes to it, not always, but certainly in this case, whereas the choroidal histiocytosis has more of a smooth appearance. What about these two amelanotic lesions, unifocal? This is a granuloma versus a metastasis. So with a granuloma, obviously patients may complain of pain. There may be cells in the vitreous. The ultrasound can be very mixed. On the indocyanin green, what's helpful is to see these hypofluorescent punctate spots. You can see it with other entities as well, but often we'll find it with a granuloma. And that's what it looks like after a subtenon Kenalog injection. And then here's another example of one where you see involvement not only of the choroid, the retina, but also involvement of the vitreous. You can see the inflamed thickening of the choroid and even of the sclera as well, which is something that so a scleritis is what you may see with a granuloma, and of course the diffuse episcleral injection. Metastasis we have talked through, so the undulating choroid, the extensive subretinal fluid, the vascularity of the lesion. What about these two? So we have a choroidal lymphoma versus a focal scleral nodule. So this choroidal lymphoma, this is actually pretty classic. So you've got this confluent yellow placoid stuff in the choroid that looks like this on OCT. So there's undulations. You can tell that it's within the choroid. It's not subretinal. It's not sub-RPE. And what's really key here is that you can see that there is involvement, that hyporeflective area within the orbit is the same process. And very often you're going to have more choroidal lymphoma in the orbit than you will in the choroid. So it's very helpful to have an ultrasound. A focal scleral nodule, this is a classic image. So you can see that it almost looks like it's emanating from the sclera and protruding up into the choroid. And another example there, just some very quick points. If you have a refractory uveitis or vitritis, think VRL and look for intraretinal infiltrates and outer retinal infiltrates. If you have a hypopium with a hyphema, think leukemia. Obviously, if there's trauma, you're not going to. This is a natural killer cell, killer T cell lymphoma. If you have large white tan clumps in the anterior vitreous, think metastatic cutaneous melanoma. And what we use now in coordination with imaging is a single blood test, which looks for 144 different oncogenes to allow us to determine and diagnose what these amelanotic lesions are. And those are the diagnoses here. Thank you.
Thank you so much. Dr. Francis will next talk about imaging characteristics of cancer treatment toxicity.
Great. And I'm going to add some pearls in with this one. I have no financial or commercial interest, so most of my practice is to treat intraocular tumors, but as a result of that, or because I'm at MSK, I see patients who are on new cancer drugs who may well have toxicity from these new cancer drugs. And so that's what I'm talking about next. Over half the people in America will get cancer, which is a really shocking statistic, but the death rate from cancer is dropping. So that means that there are more people living with cancer that could walk into your office with an eye problem from their cancer treatment. We know that traditional chemotherapy does give toxicity to the eye. You may also know that there is a grading system for the retinopathy when a patient is on a new drug. We can divide it into those that are grade 1 or 2, and typically patients will remain on drug, and that's defined as being 20/40 or better vision, whereas grade 3, when your vision is less than 20/40, that's when the drug is either discontinued or it's reduced. In my practice, if a patient is on protocol, I have to follow these guidelines. If they are not on protocol, then I'm much more liberal with drug and remaining on or dose reducing. I'd like to highlight these 5 groups of drugs which are known to give cystoid macular edema. We will breeze through these. You're probably familiar with the Taxols. These inhibit mitosis. They are largely used to treat breast cancer. They disrupt Euler cell transport, which results in fluid accumulation and CME. They get no leakage on FA. They can be reversible with drug cessation, but not always. And there are some reports, and I have some cases that have improved with anti-VEGF injections as well. This one did not improve. Calcineurin inhibitors in the cancer world, they're used for immunosuppression after stem cell transplant. They result in endothelial injury, fibrin, thrombi, and then the latter effects of that, and something called thrombotic microangiopathy. The reason I bring that up is that if a patient has high blood pressure in coordination with a headache and findings of hyperviscosity in the back of their eyes, you want to think about a thrombotic microangiopathy. This is what it can look like on OCT, so intraretinal, subretinal fluid. And if you treat the thrombotic microangiopathy with supportive measures and you stop the drug, you can reverse those findings as shown here in this patient. Imatinib is used to treat leukemias, lymphomas. It's a tyrosine kinase inhibitor of BCR-ABL. And it can result in CME, but it also results in fluid accumulation in many parts of the body, including the periocular space. And then ibrutinib is a Brutin tyrosine kinase, which can give you CME. There are other newer tyrosine kinase of Brutons which do the same thing, although there are only scattered case reports on this. This does result in FA leakage, and it has been previously treated with topical NSAIDs or steroids. It's not very common. I'm now going to skip down this list and talk about BRAF inhibitors, which are upstream on the MAP kinase pathway. If you have a mutation in this pathway, you get overactivation of it in tumor proliferation. So the purpose of the drugs is to block that. The cancers that are treated, thyroid cancer, melanoma, and some leukemia lymphomas. And about 5% of patients will get bilateral non-granulomatous anterior uveitis, but a small percentage can get FA leaking cystoid macular edema, but very rarely patients can get very pronounced inflammation in the form of pan-uveitis or a VKH-like scenario. MAP kinase inhibitors, so these are the other ones in this pathway, MEK inhibitors or ERK inhibitors, and FGFR, which is all the way at the top here because it's not actually in the pathway, but it's an indirect activator of the pathway. And these are used to treat a host of different drugs. The most common are the cholangiocarcinomas, ovarian, and melanomas. And these can result in two things in the eye, the subretinal fluid foci, but also an increased risk above what you would typically expect in a cancer patient of a vein occlusion. These patients develop fluid between the interdigitation zone and the retinal pigment epithelium. We've shown that there are 5 different types of fluid that you can see in the eye. And this is an example of how they're distributed for each patient between each eye. So see if you can find some patterns. Here are some more examples. So what you'll notice is that this is largely bilateral, that the fluid does involve the fovea, that they're multifocal, and they sort of look like these globules of mercury that are sitting on the retina. This is what happens over time. It's a bilateral process. That's at baseline. You can see that there's now some splitting here of the EZ, IZ, and RPE. And then with more time, so at 10 days, you've got elongation of the EZ, IZ, and that fluid beneath the photoreceptors. You keep the patient on drug, and with time, this will go back to normal. There's an intact IZ-EZ. The RPE also remains intact. There's no thickening of the choroid. The mechanism of this is unknown. It's thought maybe it's at the level of the pump in the retinal pigment epithelium. Key thing here is that patients don't need to stop drug. In the protocol, they did, but now we're off protocol and it's in the clinic. We don't take patients off drug. We just watch them carefully. Just some of our data, 48% of patients were symptomatic when they had the fluid. That means half the patients did not have symptoms. And for the most part, patients lost about 2 lines of vision. And once the fluid resolves, their vision improves. This is interesting. So we've plotted out the number of subretinal fluid foci with each cycle of drug that the patient was on. And you can nicely see that as you have subsequent cycles of drug, the number of fluid foci that you have decreases, which suggests that maybe there are some compensatory mechanisms in the eye, upregulation of a pump that is reducing the likelihood of these fluid foci. Also, if you block higher up in the pathway, more upstream versus more downstream, the downstream blockage gives you more severe retinopathy. Here's an example of that. Early on, when this drug was being developed, there was rhetoric in the literature calling this central serous chorioretinopathy. I hope I've shown you imaging to explain that this is not CSC. An example here, I think I've told you already, that there is no thickening of the choroid in this entity, that the photoreceptors and the retinal pigment epithelium remain intact. Unlike often in CSC, they do not, and you get loss of the outer retina once the fluid resolves. Just a reminder that vein occlusions can occur. The visual outcome with these drugs tends to be better than other reasons for having vein occlusion. Here's an example of a 58-year-old man who's on an FGFR. He's got 20/25 vision with that fluid. He comes back about 10 days later. The fluid is improved. He's still 20/25, but he feels worse. And that's because an FGFR also gives you a keratopathy. So if patients are unhappy, look on the cornea. Just wanted to note that MEK inhibitors can also make the pressure in the eye go up. So if you see an elevated intraocular pressure, if you put them on a drop, they'll respond well. And then lastly, the immune checkpoint inhibitors. There are 4 different classes of drugs. These block the interaction of the immune system to the tumor cell so that it heightens the immune system. So you can block PD-1, which is on the T cell, or PD-L1 on the tumor. There are newer class of drugs called LAG-3. The whole purpose of these is to potentiate the T lymphocyte response against the tumor cells to kill the cancer, but you can have off-target effects on normal tissue that can result in inflammation. So it would follow that if you can have unleashed inflammation, then you can potentially see anywhere in the eye, any layer, an inflammatory response. So truly, if you can imagine an area that could be inflamed, you are correct. Here are some examples of posterior segment checkpoint inhibitor-related inflammation. And to note that there is a VKH-like a clinical picture that has been reported both with and without neurological symptoms. Question, how do you spot a patient on an immune checkpoint inhibitor without using a slit lamp? So here's a hint. There's poliosis, there's vitiligo. This is what he looked like before he was on the immune checkpoint inhibitor. That's what he looked like afterwards. So these patients can have profound vitiligo. Here, interestingly, look at the choroid thickness. And after 2 years of being on an immune checkpoint inhibitor, there's thinning of the choroid, and you can see loss of pigment in the fundus. And then here is an example of a choroidal nevus that decreased over time with a patient on immune checkpoint inhibitor. I am out of time, so I'm going to stop there.
Amazing talks. Thank you so much. We're going to change things up a little bit, some scheduling things. Dr. Mooney has about 20 pneumatics to get to tonight, so we're going to have him do his talk here. It's preoperative imaging of retinal detachment and surgical decision-making.
Thank you so much to the organizers. It's really an honor to be here. When I started my fellowship, we never did imaging in detachments. And then when I started as a staff, like a year or two later, we had all these new machines and everything, and I started taking a lot of imaging, and it led us to kind of understand retinal detachment a lot better. So I wanted to share some of the things that we learned. These are my financial disclosures, none relevant to this. So when you look at a detachment, again, what do we normally think? Book for the OR or book for a procedure. But if you look carefully, you'll see these undulations under the retina. And if we look on OCT, they're not full thickness. They're outer retinal corrugations. And these became relevant because we recognized, Delomo in Italy and others, that they can lead to outer retinal folds. And these were associated with worse visual acuity outcomes in some of the post-hoc analyses from the PIVOT trial that we did. And we wanted to really understand why you were getting those corrugations in the retina, and to try to understand how we can avoid these outer retinal folds, but also other things related to the physiology of retinal detachment. And what we discovered was that in order to get those corrugations in the retina, you had to have a change in the elasticity of the outer retina relative to the inner retina, and that eventually led to these corrugations. And it all comes back to hydration of the outer retina. You know, I tell my fellows that the vitreous, the liquefied vitreous, is essentially, you can think of it as toxic to the photoreceptors. You know, think of in evolution, we do everything to avoid fluid under the retina. And when you have a retinal break, all of a sudden you're exposed to this liquefied vitreous that's very hypoosmolar, and it leads to a hydration and lateral expansion of the outer retina. And then that generates compressive forces because it can't expand forever, and that's when it corrugates in a compensatory manner. Now, we know that some detachments don't have those types of changes, such as the patients who have the myopic detachments with atrophic holes, attached hyaloid, and there it's a different pathophysiological mechanism, and we wanted to really understand what was going on. And if you look at the OCT, you can tell the difference between these dysregulated ones where you have this rapid influx of fluid versus regulated detachments where you can see the outer retina has no corrugations. And here's another example demonstrating the difference in what's going on within the retina in these two cases. So what's happening in this scenario? Well, the hyaloid's usually attached, or the flow rate into the break is very slow. So then the RPE has time to absorb all the fluid, and it's in control. So that's why we call it a regulated detachment. The fluid gets absorbed, and you're left with this high a concentration of material, and that's why you often get residual subretinal fluid in these types of cases. So it's all related to the rate of inflow of subretinal fluid that determines the physiology of what's happening. Now, what's the clinical relevance? Well, one thing we talked about was how corrugations lead to outer retinal folds. But we recognized then that corrugations were just one change in the spectrum of changes that occurs when you hydrate the outer retina. So we developed this staging system that describes the morphological features that occur when the retina detaches in these dysregulated cases. And one of our fellows was brilliant, and she realized that if you could image from the leading edge of the detachment to the break, that could be a surrogate for time. So the leading edge of the detachment's been detached for the least amount of time and around the break for the longest amount of time. And if you use that information, we can discover what happens over time to the morphology of the outer retina. And so that allowed us to develop this staging system. And if you look at this detachment, you see at the leading edge of the break, it's stage 5 where you have patchy or complete loss of photoreceptors, whereas all the way to the leading edge of the detachment, you see the corrugations. And look at how the variation in the outer retina is, and that really helped us further understand the pathophysiology. So what happens initially in a dysregulated detachment is you get a separation, but you can still see the outer retinal bands. Then what happens is that the outer retina gets hydrated, as you can see here, that thickening there. And then you start to get these low amplitude corrugations because what's happening is the outer retina is expanding beyond the space that's there between the optic nerve and the aura and other landmarks. And then you get these high amplitude corrugations as the hydration progresses. And then as you get even more hydration, you start to get a breakdown of tissue and you start to get these hyperreflective dots and eventually patchy and complete loss of the photoreceptors. So here from our paper was an animation video, again showing that initially a separation, then you get this hydration of the outer retina in stage 2, and then you get these low amplitude and high amplitude corrugations. And then what happens is that there's further thickening, so the corrugations become less defined, and that's a precursor to loss of the photoreceptors, the inner and outer segments. And so we looked at that, and as expected, it correlated with the visual acuity and also the time to presentation, but not as nicely as you would like, and therefore we recognized that OCT was very useful. These are 3 patients who all presented to me who said that their retina was detached for 1 day, but clearly we can see that the one on the top is probably the most urgent to fix, and then the one in the middle, and then the one at the bottom. So we wanted to look at the impact of morphological stage on visual visual acuity. And here you can see the 12-month visual acuity nicely correlates with the stage of presentation. And even when we do a multivariate regression analysis, factoring in all kinds of variables, including height of the detachment, we found that the stage did help us. So if we look at stage 1 and 2 versus 3A, there was no difference in the one-year visual acuity outcomes. But once you look at stage 3B, that's really the critical turning point when you get those corrugations. And it makes sense because corrugations represent a change in elastic modulus, which is due to a structural change in the outer retina. And when that happens is when you're going to get worse outcomes over time. So I have a few minutes left. I just wanted to talk about one other thing related to this, which is hydration within the fovea. And the fovea has a very unique anatomy of the Mueller cell cone and the central foveal bouquet, and therefore the Mueller cell cone is like a plug that kind of holds those central photoreceptors. And we recognize that there's a change that occurs in the fovea that's different than those corrugations because of that Mueller cell cone, which is this bacillary layer detachment, which you see in other inflammatory conditions. In retinal detachment, it's secondary to a hydration of the retina. And again, because the Mueller cell cone is like a vise holding these photoreceptors, the retina does not corrugate in that region. So we wanted to look at what types of these ballad-related abnormalities you get, and we recognize that some of them progress to what we call a ballad lamellar hole, and that could be the precursor of a full-thickness macular hole. So here's the spectrum of changes where you see a subtle change in the myoid zone, and then a full bacillary layer detachment, which is, again, a separation within the myoid zone. And then what happens is the cystic changes that you get in the Henle fiber layer breaks down that anterior ballad wall because it's unstable, and you eventually lose the Mueller cell cone, and you get this ballad lamellar hole that you see there. And what was, and again, here is just showing you the evolution of those changes. Here you can see those cystic changes causing a breakdown of that anterior ballad wall, leaving you a ballad lamellar hole. And so for the first time, we recognized the pathophysiology of macular hole in RD was all related to hydration of the outer retina and what happens in response to that. And that's this paper in IOVS that where we described that. And here you can see how the ballad lamellar hole over time will progress to a full-thickness macular hole. Think of a full-thickness hole in RD as a rapid degenerative change. And so even when you treat it, it's not going to have the same outcome because you have a loss of the outer retina, and so the outcomes will be worse. And here you see in the fovea, as you go down that progression from no ballad lesion to a ballad lamellar hole and a full-thickness macular hole, the outcomes are much different. So just to show you the same animation video, but with reference to the fovea, here again, you're getting this hydration of the outer retina, and that's causing this lateral expansion in the perifovea, which leads to these corrugations. But because of the Mueller cell cone holding that central foveal bouquet, instead of it corrugating, it compensates by splitting in the myoid zone, which is an area of weakness leading to this ballad lesion. Then you get a breakdown of the anterior ballad wall, you lose the Mueller cell cone, and then what's left there is actually not viable tissue, it's just interphotoreceptor matrix that eventually goes away, and you get this full-thickness macular hole. I'd like to thank all the brilliant people I've worked with who made all of this work possible. Thank you so much.
Just amazing talks there. And there was a slide there at the end that had to be cut short that I'll put a plug for. Dr. Mooney has an amazing Telegram chat for people that want to do pneumatics where he's very generous in helping people and refining their techniques. I have a few questions, if there's none from the audience yet, for Dr. Francis. Actually, Dr. Reeves, if you could use the microphone. Thank you so much.
Hi, thank you. Dr. Francis, I was hoping that you could explain what some of the screening patterns or recommendations might be for patients who are on oncologic therapy, especially to catch patients who may have subretinal fluid but not yet be symptomatic.
Yeah.
Thank you.
So many of the guidelines are actually defined by the protocol, and the protocol is written by typically the drug company that's generating the drug. So when it's in trial, it's actually very straightforward and clear on how we should screen these patients. In terms of once the drug is now in the clinic, that's when it becomes much more fuzzy. And the oncologist, if it's required by the FDA, which is true for some of these drugs that give you anterior segment toxicity, those patients have to have frequent and consistent evaluations by an ophthalmologist. But for the ones that give you a retinopathy, there are no guidelines. So we're really at the whim of the oncologist. So if a patient says to their oncologist, I've got blurry vision, then they're probably going to send for an eye exam. And sometimes there's a problem, and sometimes they need new glasses.
And it's tricky because with the way, and if I understood what you were saying in your talk, Jasmine, around being a little bit more liberal once they get out of the protocol. And it's hard because in some of these cases, it's written within the drug insert at what it is, and you're going in the opposite direction of that. The oncologist is saying, wait, they're 20/50, why aren't you stopping it? And it can be a really tricky thing to navigate in that way as well. I'm curious how you go about that. Is that really a patient-tailored discussion in that regard?
Definitely patient-tailored. There are some patients who will not tolerate under any circumstance having a vision less than 20/30. And if it means coming off a drug, the stakes are that if you come off the drug, there's a high likelihood you're going to die.
Mm-hmm.
So patients choose to retain better vision and get to the end of the line in terms of treatment options available to them. So because of that, it has to be a patient-tailored decision. And the crucial thing, which I really should have emphasized, is having a conversation with the oncologist. They are so grateful when you see their patient, and they're so grateful when you call and give them information about their eyes that they cannot glean themselves because they cannot do the exam that we can. So I really encourage you to reach out to the oncologist and make a decision together for the patient.
Thank you. Dr. Francis, some quick rapid fire questions. For sclerochoroidal calcifications, do you work those patients up when you see them?
I tell patients we could work it up. We could look at phosphorus, magnesium, potassium. We could look in blood and urine, and we might find something, we may not. The really motivated patients will do it. Blasé patients will not. I would say I'm actually more surprised than often that we do find something.
Okay.
And meaning that patients will find that they're magnesium deficient and they should take magnesium. Now, whether it's really related to their sclerochoroidal calcifications, I don't know.
Thank you. And then probably for the sake of time, you couldn't touch on it too much, but you had an interesting slide that you're using cell-free DNA to diagnose some tumors. Is this something specific to your institution, or is this widely available? How do you recommend people incorporate that in their diagnostic workup?
Yeah, cell-free DNA looks at DNA that leaks from the tumor into the blood. So by taking a vial of blood, you can figure out what the DNA is without actually touching the tumor. It's really relevant to intraocular tumors. MSK has our own assay. It is available through a commercial route. The company is called Sophia Genetics, SOPHIA, I believe. But there are other assays as well. I think Foundation One has a very good assay. I encourage people to use it. It's a great non-invasive way of getting information about an intraocular tumor.
Thank you. And then to Dr. Mooney, really great talk and great images. Thank you for your contribution to our understanding of retinal detachments. Of course, we know that you obviously strongly feel that pneumatics might provide better vision benefits for patients. When you showed the valid full-thickness macular hole development, you highlighted that many of the macular holes actually don't end up closing when fixing the detachment. So in those cases, your talk was called Imaging to Guide Surgical Decision-Making. Would you think that vitrectomy right away would be better, where you sacrifice some of the benefits of a pneumatic for retinal reattachment, but you have to fix the macular hole quickly if you heal? Or would you recommend pneumatic first, let the macular hole sit there longer, and then vitrectomy after that? How do you kind of weigh your pros and cons in your head for those cases?
Yeah, I think that, first of all, I focus on just attaching the retina first. Like the patients show up at any time. They could show up in the evenings or, on a Friday or, you don't have OR in the next couple of days. So, generally speaking, we treat the detachment even when you have a full thickness macular hole, it's due to a degenerative process that we're seeing. 30%, a third will close on their own with the pneumatic. And so, and then usually within a month, I go in and do a vitrectomy. And in these cases, I like to do an ILM flap because, as I mentioned, the outer retina has degenerated. I think they have a slightly higher risk of worse visual outcomes or non-closure. So my usual strategy is treat the detachment first, and that could involve any of the techniques, but usually pneumatic in our practice, depending on where the breaks are, and then a delayed treatment. Now, if the patient had a 6 o'clock break, let's say on presentation, I'd probably book it in the OR and do everything at once.
So do you position them differently if there is evidence of macular pathology utilizing the bubble at all?
No, because it seems counterintuitive, but the macular hole has nothing to do with the etiology of the detachment itself, of the fluid inflow. There's no, it's all from the causative break. And so we normally steamroll and we do face down for 6 hours, and maybe during that time it is helping the hole close. I don't know, but we're not really focused on the hole at all, and we don't think it's relevant to the detachment resolving or not resolving.
So Rajiv, your imaging and the mechanistic thought process around it, just is fantastic. It's really, it's interesting because when we started doing intraoperative OCT in RDs, we weren't sure there was relevance there. And one of the things that we found is when we put PFO down, the amount of foveal abnormalities that existed was way higher than expected. Many of times we were seeing either full thickness macular holes that were undetected or near full thickness macular holes. And we didn't exactly understand why that was. And it's so, in many cases, it's really hard to get a foveal OCT pre-op, in these patients. And now I'm realizing that almost all of them probably had bacillary layer detachments. And then when you put PFO down, you're also now putting a different mechanical stretch on it. What was interesting is that in our series, almost all of those closed on their own, but then some of them reopened, like at 1 month, 2 months later. And again, you think about it as probably this inherent weakening from that. So congrats on that. It's really, really great work.
It's very interesting. Everything we do in VR surgery is based partly on efficiency, economics, what we've learned. There's been no randomized trials showing that vitrectomy is better than, or using PFCL is better than not using. Like, these are all things that we do that make sense to us to attach a retina. But we're now realizing that all of these things have their detriments, including air fluid exchange, including PFCL, including the use of gas. They all have an impact on the photoreceptors, and we're just now scratching the surface of what those impacts are and how we can improve our outcomes. And I think we have this tendency to want to do everything we can to make sure the retina is attached on the next day, but at what cost are we willing to do that? So we have to really, as we learn more, be open-minded and understand the impact and the physical, biomechanical impact of these things on the retina and how we can improve outcomes over the next few decades.
Rajiv, I just love your work. I think you've sort of shaped the way that I think about retinal detachments, probably more so than anyone else in the last half decade. When we think about that ballot macular hole, when you close them, I think we sometimes have primary macular hole associated detachment from sort of vitreofoveal traction, and then you have this, which is more of a degenerative one. What's the delta in visual outcome when they are both closed? And then if you had any thoughts for the second question, when you do a retinal detachment surgery by vitrectomy and then you end up with a secondary macular hole, is that sort of similar to the vitreomacular traction mechanism or similar to the ballot mechanism that's degenerative in nature?
Yeah, so the first question is the delta is significant. I think that it's probably 2 to 3 lines of vision. Like, it's not unusual to have one of those ballot lamellar holes end up with 20/60, 20/70. Now, over time, things do get better a little bit, like there's some reconstitution of the outer retina, but we just looked at the difference between idiopathic macular hole type of pathology and the ballot, and it's very different because of the loss of the outer, of the photoreceptors there. So they are likely to do worse, and that's why I'm more likely to do a little more when I do the surgery, like an ILM flap or not. The macular holes that happen after vitrectomy I find very interesting, and I don't think I understand it fully, but I do sometimes see a little bit of an ERM on the surface, like, you'll see like a small hole with a little ERM, and I just wonder if it's a different mechanism, but I think a lot of times we've actually not diagnosed the ballad lesion preoperatively because either we didn't do imaging or it was too bullous to get a good scan. And so you do the vitrectomy, you see like a lucency there, but you're not really sure is there a hole or some lesion. So you fix the detachment. They're filled with gas for a month. Now they come back at 2 months and you do an OCT and there's a macular hole there, but it may have been a ballad lesion all along. So I think that's.
I think, given what you showed, I think, and what we saw with intraoperative OCT, I bet there is an inherent weakness, and even a more mild, tangential tractional force might open it up like that.
Awesome discussion. For the sake of time, we'll move on to our next session. Thank you so much. We're going to have Dr. Yasha Modi speak on imaging updates in uveitis.
All right, everyone. It's late, and we're going to get a little unhinged here. So this is imaging in uveitis. And by the way, how awesome have some of these talks been? They're just kind of really just amazing talks and just like really great food for thought. And, I always ask myself, like, why am I even here today? And the answer is because I'm here because Sunil couldn't come. And, Sunil has kind of been a really big part of this meeting for 15 years or 14 years now. But it turns out he's actually in clinic trying to make money to pay all of their salaries while they are here lecturing all of you. So this is Sunil in clinic. And I asked him, I said, Sunil, what should I say? You always give like the best uveitis lecture. And like, how can I possibly take this spot? And I'm like, should I just show them a Bichette scrotum like you do? Or, maybe I should show like a cool case of cysticercosis, like, because everybody loves worms during dinner time. And so I said, Sunil, can you just give this lecture remotely? Because I just don't think I could do this. And he says to me, just teach them everything that I know. And I said to him, but I don't know everything that you know. And he says to me, you'll be fine. Imaging helps. And save that kicked by a cow case for me. And I said, kicked by a cow? And he says, exactly. So some of you actually may know this kicked by a cow case. It's a real case, by the way. So the question is, what makes Sunil so good at uveitis? And I think a big part of this is that he has a reliance on multimodal imaging. And now as a uveitis community, there's actually a sort of a task force that is designed to try and provide guidelines on what defines multimodal imaging in uveitis. But I want to kind of focus in a little bit sort of more clinically focused, like how can we use imaging and how can that be helpful in everyday clinical practice? I think diagnostically it's really important. OCT is remarkably helpful here. It can narrow a differential diagnosis and it provides understanding of disease severity and response to treatment. So let me show you a couple of cases. OCT signs pay attention to the layers affected. And when combined with fundus autofluorescence and exam, these are highly specific. So take this case, 37 years old, blurred vision, 3 days, you sort of see the shoddy ellipsoid zone layer attenuation and loss. When you take the fundus photo and fundus autofluorescence, we all of a sudden get a pretty characteristic diagnosis of mutes. Take this case, 42 years old, blurred vision, 9 days, came to see me at Bellevue Hospital in New York City, and you sort of see this annular placoid lesion. And when you look at OCT, like this is sort of the classic, like every resident and fellow needs to know this case of syphilitic posterior placoid chorioretinitis. This one's a little harder though, 56 years old, transplant patient, and comes in with a temporal scotoma. And the fundus photo doesn't really show a whole lot, but when you look at the OCT, all of a sudden you're sort of seeing this full thickness disruption and hyperreflectivity just nasal to the fovea. And this is a case of CMV retinitis in an immunocompromised patient. So when you think about the OCT, always try to put the OCT over the pathology and then ask yourself what layer is affected. Is it the outer retina? Is it full thickness? Or is it choroidal and retinal involvement, like in a toxo case. So here are some examples. One is MUDES. One of the cool features, by the way, outside of just the size of the lesions to differentiate MUDES and AMPI, is that AMPI oftentimes involves the outer nuclear layer. So we get that hyperreflectivity of the outer nuclear layer, and then eventually you get atrophy of the outer nuclear layer as that goes away. And we already talked about syphilis on the other hand. Also look at the choroid. Is it uniformly thickened, as in VKH, or is it sort of focally thickened, as in sort of toxoplasmosis? So here are a couple of other cool cases. This is a 69-year-old who presents with 10 years of vitritis. That's kind of a long time to have a diagnosis of vitritis. And then I've highlighted in red that this individual not only has AFib, but also has complete heart block. So when we look at the OCT, you sort of see like almost looks like these like little iron filings on the surface of the retina. And of course, assume it already knows this answer, and this is amyloidosis, exactly. And so here you could sort of see another example of these like really, really cool like needle-like findings that are pre-retinal deposits on the OCT. These actually can form around the anterior and posterior lens capsule as well. And these are cases of familial amyloidosis. So here's another case, 72 years old, presents with floaters in both eyes. And what we see on the OCT is sort of like this like sort of linear, sort of hyper-reflective line. So take a look at that for a second. Here are some other cases. Now, actually, I find this to be more helpful, which is that when you look at that image on the right, not only are you seeing that vertical hyperreflective line, but you're seeing a separation of the RP and Brooks membrane. And this is a case of primary vitreoretinal lymphoma. And you can see these vertical hyperreflective lesions in over 50% of patients who are diagnosed with this, and they can be frequently outside of the macula. So if you sort of see something that looks a little bit white in the retina, always good to put that OCT scan through it. And just remember, lymphomatous infiltration can be practically anywhere in the retina. It could be under the RPE, it could be under the retina, or it could be intraretinal, as we sort of just discussed. It could be as subtle as this. This almost looks like a case of macular degeneration, and here we sort of see ellipsoid zone attenuation, as well as what could easily be mistaken as just drusenoid PEDs, and this is also a case of primary vitreoretinal lymphoma. So a less specific OCT sign, but beware. This is something that I think we will all see. This is a 28-year-old with blurred vision for 2 weeks and has dense vitritis. So maybe the view's not so good, but you start to see these pre-retinal precipitates. And when you see this, while this can occur in multiple diseases, you have to be thinking about infection. This has to be in the top of differential toxoplasmosis, syphilis, acute retinal necrosis, or endogenous endophthalmitis. Only after you've worked your way all the way through that differential should sarcoidosis enter into your mind. So just think pre-retinal precipitates is infectious until proven otherwise. So how about ICG imaging? This is a patient who came to see me. He was actually admitted in the hospital, 32 years old. He had renal failure, and he's noticing more floaters, so we get an ophthalmology consult, and it almost sort of looks like this person's got multifocal choroiditis. That's a huge differential. And so you're trying to help your inpatient team to make sense of this, and so this patient actually kind of came over for some imaging, and we get an FA. FA is really not that impressive, maybe a little bit of disc leakage. You're also seeing those sort of like areas of like, staining from those chororetinal scars, but then you get the ICG. And what you see on the ICG is you sort of see these multifocal hypofluorescent spots. And actually, Dr. Francis showed this a little bit earlier. So when we think about, well, what is the differential diagnosis of these hypofluorescent spots, all of a sudden it becomes way smaller. You have infectious tuberculosis, non-infectious sarcoid, birdshot, VKH, SO, and then you have masqueraders like uveal lymphoma. Noticeably not primary vitreoretinal lymphoma. This is a uveal lymphoma potentially on this differential. So this person undergoes a renal biopsy. It shows non-caseating granulomas, and you make a diagnosis of sarcoidosis. So imaging can also be useful for assessment of disease severity in response to treatment. Take this patient, 35 years old. She's been seeing me for a number of years. She's got these crenated KPs, 1+ vitreous cell. Otherwise, doesn't look too bad. So FA at presentation, not so much leakage, maybe a little bit of staining from chronic like pigmentary changes. And she's bothered by the floater spurter visions. Excellent. So we decide to actually observe her at this window of time. Fast forward 1 year later, she says, I'm definitely noticing something's different. New floaters, vision's worse. Her vision in both eyes is actually pretty good. But here we go and we get repeat imaging on this patient. And when you look carefully, now she's starting to have some sheathing along the veins. When we repeat the FA, all of a sudden you can now start to see evidence of vasculitis. So this is somebody where actually we learned from our coal counterparts that leakage on ultra-wide field FA is really a good surrogate marker of inflammatory activity. And I would argue this is pretty much the gold standard really in uveitis to understand disease activity now. But it's important to realize the pattern of leakage is really important. Diffuse vascular leakage, rather than just that peripheral vascular leakage, is an independent poor prognostic factor when you compare like those individuals with and without CME and even independent of vitreous haze and cell. How about fundus autofluorescence? Here you sort of see this large superior placoid lesion. Not surprisingly, this person has syphilis. And when you give IV penicillin, you could sort of see the changes of that autofluorescent pattern over time. At presentation, day 14, and it's starting to go away. And by day 92, you can't even make out that there are any changes as the ellipsoid zone reconstitutes. So I'll leave you guys with this last case. Is this patient well controlled? She's 41 years old. She's got pain, photophobia, low back pain. She has a known history of B27-associated uveitis and ankylosing spondylitis. And she comes in for a second opinion. She's been on prednisolone every hour for 2 weeks, so really well treated. She says she's feeling 90% better, and she has trace vitreous cell on my examination when I see her. When you look at her OCT, though, it looks pretty much normal, but I want to cue you into the macular cube. Look at the volumetric cube, and all of a sudden it looks way more red on the left side. So she's actually got like overall enhancement of the macular cube, and if you look along the vessels, it's just a little bit thickened in that area. And it turns out actually in the ankylosing spondylitis, we can also see thickening in the contralateral eye. And this is what her FA looks like. This is anterior uveitis. And here you can sort of see massive extensive peripheral vascular leakage. So actually at this point, we started her on oral prednisone, we talked to her rheumatologist, and at this point, she agrees to go on Humira treatment. So what I've learned from Sunil, when in doubt, it's syphilis. When you're not sure, get imaging. Multimodal imaging can narrow a tough differential, and ultra-wide field FA is critical for understanding disease activity. And don't forget autofluorescence when you're considering placoid disease. Thank you.
Our next speaker is Dr. Danny Memo, and he's going to talk about how he uses imaging to plan for vitreoretinal surgery.
Great job, Yasha. Thank you. These are my disclosures, not relevant. So we're going to start with a case. This is a 61-year-old female. She's a same-day add-on in my OR day for a vit buckle. And she was scheduled, as I said, for a vit buckle, 1+ NS. Exam was done without photos, so not everyone gets photos for all the patients, which is fine. I have a Friday OR, decided to take the case, but I wanted to get photos first, so just had the patient kind of go upstairs, get some pictures. Here's the patient. You see a macula involving fovea potentially sparing retinal detachment. We see some potentially early PVR infratemporally, and there's either a retinal dialysis or a large giant retinal tear. You'd have to depress to see what's going on there. But more importantly, I have an OCT, and it's looking at not just the macula, but also over the nerve, and we can see that the hyaloid is very much attached. I don't know if I have a laser pointer here, but here we can see that the posterior vitreous is definitely attached here on this picture. So this totally changed management. This case was scheduled for a vitrectomy scleral buckle, but I definitely changed here to do a primary buckle because I don't like to do a vitrectomy on a detachment with a hyaloid attached if I can help it. Here's another image showing you that the hyaloid is down there. When they're very down, if you just had an OCT looking only over the macula, you might not be able to tell. But here, extending out to the nerve in this young patient, you can see that the hyaloid is still attached there. So this patient underwent buccal, cryo drainage, and SF6 and had a nice result. So this was an 80-year-old female who presented for a second opinion for recurrent vitreous hemorrhages in the left eye. She was 20/30 in the left eye. She is pseudophakic in both eyes. And again, she's 80 years old. There's no TIDs on exam. So first imaging is that I had a suspicion that, why is this lady getting recurrent hemorrhages? So we did get a UBM. And we do see that the IOL is rubbing on the ciliary processes and not the iris. So this is probably going to be a case if the patient wants to maybe reduce her risk of hemorrhages to exchange the IOL. Should be a fairly routine vitrectomy. She's 80 years old and pseudophakic, two very strong risk factors for likely having a PVD. Exam doesn't really allow me to see if there's a PVD based on, looking for a Weiss ring with my 90. But if you see the OCT, you can clearly see that despite her being 80 years old, her hyaloid is still down in that left eye, very similar to the right eye. So here we go to surgery, and fellow does a great job clearing the vitreous hemorrhage very excitedly. The fellow checks for a PVD, is very happy with what they see. I decide not to keep talking. Fellow resumes the vitrectomy. I decide to finally ask, is there a PVD? Well, fellow's kind of confused. Well, she's 80. Yeah, there's a PVD. Okay, let's check with some staining, Kenalog. Oops, I guess there wasn't a PVD. So these cases, I really find that pre-op OCT is very important at increasing your pre-test probability for if the hyaloid is attached. There's many times where you'll just kind of go down with the cutter, you think the hyaloid is up, and you're really doing a semi-good job at really assessing for the hyaloid. If you really know it's down, it increases your surgical efficiency, and it can prevent you from having some mistakes in cases where you're pretty sure the hyaloid's up, but imaging is clearly showing you that it's not. So we always get an OCT on almost everyone in our clinics to use it to help you think faster and smarter intraoperatively. Obviously, the vitreous status can influence the type of surgical procedure that's chosen and influence your pre-surgical spider sense, as Dr. Kaiser, one of my mentors, always talks about. OCT is more practical than getting a B-scan. B-scan is highly operator dependent, and not all images get saved for review as well retroactively. OCT review, however, is also reviewer dependent, so I suggest you sharpen your skills based on constantly looking at these images and testing them in the OR. OCT, however, is not supposed to be that great if you read the literature. B-scan is apparently considered one of the gold standards for assessing for a PVD. If you look in the literature, the sensitivity of OCT is 50 to 70%, specificity is 80 to 90%. B-scan is published to have a little higher sensitivity and specificity in the literature. However, what are the studies that are determining these numbers? So here's a study looking at the sensitivity of OCT in the diagnosis of PVD. And actually, in some of these cases, especially in the top images, they are counting those images as having a PVD. But clearly, when we operate, we know that these cases have the hyaloid attached not just at the nerve, but perhaps in the nasal retina, all the way up to the equator. These would not be something that I would call having a posterior vitreous detachment. This is another study looking at the accuracy of biomicroscopy, ultrasonography, and OCT in detecting a complete PVD. And in their methodology section, they define how they look at PVD. They confirm it when a hyperreflective line was clearly separated from the neuroretina. So if it was just separated from the neuroretina but still in the picture, they're going to call that a PVD. But that's not really a complete posterior vitreous detachment. So do I trust the OCT interpretations? Who are the graders of these studies? Are they really looking through every raster? In cases where I'm not sure, almost always you can tell by one or two rasters, but cases where I'm not sure, I scroll all the way through all the rasters, and you can usually tell it then and be pretty sure what's going on. You want to know how these studies define PVD? One of my former mentors and one of my great co-residents, Sushant Wagli at Ryan, did a study utilizing OCT to identify PVD in patients with RD. And in my opinion, humbly, they used a definition that I would consider very accurate. They looked at all 31 rasters. They got OCTs over both the nerve and the macula. That's actually their standard at their practice. And they defined as you had to have a separation of the posterior hyaloid to be present in all 31 of 31 raster scans before they called something as having a PVD. A partial PVD, where the hyaloid is detached in the premacular space but not at the optic nerve, was coded as not having a PVD. I can be wrong, however. Okay, this is a 62-year-old female that I saw in my clinic, and I punted to my former partner, now current boss, Dr. Srivastava, for OR the next day, and I said, hey, there's a PVD. You should book this as a vit buckle. Add on to my colleague, vit buckle, op note, actually very adherent hyaloid. Normally he doesn't say that, so that must have been, it was definitely a very adherent hyaloid. So going back and trying to always analyze, what went wrong, if you look closely, you can see the premacular bursa space there, and if you scroll through, it becomes a little bit more obvious. We're very busy in our clinics, though, so it's really important to, train yourself very well to recognize these things. This here is a 69-year-old male, 4 months of a chronic retinal detachment, pseudophakic in both eyes, 2300, and they had a little trauma. They fell down some stairs. So another way that I use pre-op imaging, this one I also show the OCT here. So we do see that the hyaloid is down. But something we also note here is this was a trauma. It's chronic. This patient was a little bit hypotenuse, and I'll get to that in a second. So in this case, the posterior hyaloid was attached. I used dilute triamcinolone to help visualize the posterior hyaloid. But if we go back and look at the choroid, we see that there's these undulations there, okay? So B-scan showed choroidal thickening in both eyes. As a uveitis specialist, I do surgery on a lot of patients with choroidal thickening, and I've, from fellowship to early on, I had some traps of trocars being in the suprachoroidal space. So for these cases, if I know there's choroidal thickening preoperatively, I will just go straight into the trocars. I tell the fellows, no beveled entry, and you're just trying to reduce your odds for error, reduce your odds of a suprachoroidal trocar where you kind of have to now waste some time maneuvering and fix that issue. I'll also consider a 6mm cannula for infusions in these cases to try to reduce the odds of infusion going suprachoroidally. So I recommend in inflamed eyes or chronic RD to consider the choroidal status to influence your trocar insertion. This patient ended up 20/60 at vitrectomy scleral buccal with silicone oil. Lastly, I'll talk about schisis of the nerve fiber layer and epiretinal membranes. This was a phenomenon beautifully described by Stanley Chang and the team in New York. They defined schisis of the RNFL as hyporeflective linear spaces parallel to the ILM of varying length and depth with hyperreflective bands at the level of the RNFL. We'll see some photos here in a moment. They characterize schisis of the RNFL as either being focal or diffuse based on disc diameter, location with or without outside the papillomacular bundle, and whether the schisis of the RNFL protruded through the ILM or not, which they call the spaghetti sign. So these are some examples of schisis of the RNFL with and without the spaghetti sign. And the second and fourth rows are showing these patients post-operatively. And what they show is that the schisis of the RNFL resolves, but they make careful attention to say that they did not peel those areas. And if you're ever doing membrane peels and you're wondering, oh my gosh, this tissue here feels a little bit integrated with the retina, it doesn't seem like real ERM, you're sitting there and fiddling around and wondering what you're supposed to do. Well, if you know in pre-op that you actually had schisis of the RNFL, you would kind of know what area that area might be in and pay close attention to it. These areas I don't touch when I see them in the OR. That top picture is kind of showing you how they look with that little yellowish appearance. I don't touch them, and they end up being totally resolving post-operatively. Here's some other examples from their case series. And here's a patient of mine. This is not called the spaghetti sign. This is just schisis of the RNFL without the spaghetti sign. So we looked at all of our patients at Cole that underwent ERM surgery and found similar results to Stanley Chang. About 50% of patients actually have this, and almost all of them resolve actually by post-op week 1 OCT with membrane peeling. But this I realized early on that maybe there were some times in ERM surgery where I was fiddling around and I ended up leaving it alone, and now I just can leave it alone much more comfortably with pre-op imaging. So I recommend looking at the macular cube prior to ERM and MAC hole surgery. Avoid peeling schisis of the RNFL. These areas totally settle down, and you're probably going to do less damage to the nerve fiber layer and ganglion cell layer if you leave them alone. Thank you very much.
Nice work, Danny. Our final speaker of the evening is Dr. Alexandra Rachiskaya. She's going to be talking about surgical imaging, intraoperative OCT beyond the macula.
Thank you so much, and thank you to all of you for being here. I feel like I saw some of you at 6:30 in the morning, so it just highlights how much we love what we do. And I'm going to talk about intraoperative OCT. These are my disclosures, which are not relevant. So Justice and many others have looked at intraoperative OCT and have really studied what are the potential benefits. But it always comes to does it really help me when I take care of my patients in surgery? And I think when we think about intraoperative OCT, most people think that it's most useful for macular pathology. And it's cases like this, if you're involved in gene therapy, for instance, this is a case of X-linked RP, and we have to deliver subretinal gene therapy in the macula. So you really want to make sure that you're in the right space as you initiate this bleb, and you want to make sure that as the bleb propagates, that you have a nice inversion of the foveal contour without creation of the macular hole. And there's a lot of interest also trying to measure these blebs, so we can ensure that the correct dosage was administered to this patient. We also, I think, sometimes find that in kind of cool cases, like this case of recurrent optic nerve pit, intraoperative OCT can be helpful. This is a patient who's 19. He had 3 prior vitrectomies elsewhere, comes for a second opinion. Everything else has been done. Laser has been done. ILM has been peeled. You can see this multiple blebs of the prior subretinal fluid, and he still has significant subretinal and intraretinal fluid from his optic nerve pit. And in this case, we decide to do the amniotic membrane graft. And I think it's really important that the position of the graft is appropriate. I'm using here a bimanual technique and ensuring that it's positioned in the pit without damage to any structures. And you'll see here that I'm using intraoperative OCT to confirm the position. But what's more important is that next time I'm going to go to air, and I just want to make sure that there's no dislodgement of movement as I continue in my surgery. And you can do intraoperative images. This is a phakic patient, and you can image intraoperatively under air, and I have a nice fill, and I feel very, very comfortable here that my job is done. I don't need to now poke more, and potentially cause some damage. And this patient did really well. I've been following him now for several years, and there's no recurrence. But what about peripheral retina? And I think that there's hesitation to image peripheral retina. Most people, once again, say, well, it's just going to add time to my surgery. I want to be efficient. And is it really going to change the management? And I will argue that there's a particular case that in my hands, the intraoperative OCT really changed the way I think of surgical management and how I manage these patients. And these are the patients that I don't know how I get all these patients, but probably Danny sent them. And he said the hyaloid was good. But this is a patient with combined retinoschisis and retinal detachment. So if you have a retinoschisis, to get to retinal detachment, you have to have an outer retinal defect and an inner retinal defect. And a lot of patients have huge outer retinal defects and don't necessarily progress to retinal detachment. But in this case, and I don't know if I have a pointer, you can see there's large outer retinal defect and this tiny relatively tiny inner retinal defect. But you're lucky if it looks like this, because most of the time the inner retinal defect is really, really hard to find. Like in this case, where we thought on the exam in clinic that we had the spot where there was that inner retinal defect, but when intraoperatively we imaged, we see that there's very thin inner retina and the outer retina defect is here. But there was actually, the inner retinal defect was totally elsewhere. And you really want to be careful creating unnecessary holes in these patients in the retina as you're trying to drain these cases. So I'm going to share this case. And here you can see this large outer retinal defect, but it was very hard to find the inner retinal defect. And we're doing this intraop OCT, and once again, you see beautiful outer retina, very thin inner retina. And as we keep going, there's this tiny little hole. And a lot of times these patients don't have the classic horseshoe tears. They have this very small defects in the inner retina. And you can see this beautiful edge of the outer retinal defect. And you can see the communication between the cavities, which caused the problem in the first place. And you really need to collapse both of these cavities to treat this patient. We mark it, and then we can confirm under PFO that we collapse, in fact, both cavities, and we can see our markings with diathermy. So we laser both the inner and the outer retinal defects in this case, and I put this patient under C3F8. I kept them phakic. I also add a buccal in these cases because I think the vitreous base in these patients is not normal. And this patient did really, really well. I think there's this misconception that these patients don't do well. I think if you take time and really treat the pathology, these patients do really well. This is the macular OCT, and then in the periphery you can see kind of this the laser that we did. This is the very thin inner retina where there was a large outer retinal defect. Now sometimes it's not so easy, and this is a patient who also had schisis detachment, and this patient also had an ERM, and everything looks a little chronic. You have this ERM, so you wonder if there's a little PVR. This doesn't look very healthy, and then we thought there was all this maybe inner retinal defect, but in surgery, nothing is moving. You're not getting that Schlering. You're really kind of lost where you're going to drain from. And so in this case, intraop OCT was super helpful. You see this thin inner retina. There's that outer retinal edge of the outer retinal defect. And then we found all the way in the periphery, totally separate inner retinal defect. You see how there's two cavities, and the outer and inner retinal defects in this case don't communicate. They're separate. In the first case, they were like kind of on top of each other, but here they're very distant to each other. And you have these two cavities. We mark it so we don't lose it. And then we put, this is my beautiful rendition, right? So you have the inner and outer, and then the RP. So you have two cavities. And to treat this pathology, you really need to collapse both. And so we peeled the ERM in this case. And then we put PFO. And that way we could see that we actually did collapse both cavities. And then we lasered both of those areas. But these can be very, very hard to find because it's, like I said, they're usually small holes, and you don't get that beautiful Schlering effect that we use, in cases of standard retinal detachment. And once again, this patient was left under C3F8 gas and left phakic, and we put a buccal on this patient as well, and she did well. And so I think when we look at these cases, I would just encourage you, if you have access to intraoperative OCT, I don't use it in my day-to-day bread and butter cases, but it can definitely be helpful in macular and peripheral pathology when you have this complex anatomy. And I think if we take time with this more challenging cases with retinoschisis, outer retinal holes, and retinal rhegmatogenous components with inner retinal holes, it can really help you find the pathology and lead to successful reattachment. And I just would like to thank all of my colleagues, all the people in the OR who helped me do this imaging, and all our fellows. Thanks so much.
To you first, and so you gave a great talk. You showed a lot of interesting cases. Uveitis patients are really challenging from the get-go. So how do you decide on what imaging to do on a uveitis patient? Are you doing everything on every single patient every single time, or how are you deciding?
No, I think my default, before they ever come see me like a new uveitis patient, is just fun as photo OCT. And based on what I see, you just get a general understanding, like, do they have choroidal lesions? Is it just like an intermediate uveitis? That's when they're going to go back for an FA. If they worry about choroidal lesions, then they're going to get FA ICG. And I sort of tend to tailor this is like kind of actually to what Justice was saying about workflow, this is where uveitis is kind of terrible, right? Because you can't just sort of say, I'll just get these images in 2 months. You know, you're like, you have to kind of get them on the same day of clinic to help you with that differential. And I think a lot of times I'll draw out exactly what I want, about like where I want to get OCTs, and then I send it to my photographer. They go back to get more imaging.
Okay, any other pearls for things to look for? So what do you look for on the OCT? What do you look for on that initial photo when you make that decision?
Yeah, again, I think a big part of it is a really good exam. Nothing beats a good exam. And I think the way I think about imaging is a good exam in uveitis, like you're building signs to a differential, and every image that you acquire should also be another sign that narrows that differential. I think what makes uveitis so daunting to trainees is that when you look in your textbook, the differential can be like 40 things. And your goal is to try and bring that down to like 4 or 5 working possible diagnoses. And then when you get that imaging, hopefully you're down to just a couple, and that's where your labs and then your systemic imaging can really sort of narrow your focus. But I think targeted imaging to the areas of pathology that you see is kind of like the next step after your first clinical evaluation.
Danny, for the OCT preoperatively in RDs, I mean, I couldn't agree more. I think it's really critical, gives you so much information. A couple of things in terms of that I've seen. One, I'm not sure in any eye that I've taken to surgery, if I can see the hyaloid on the OCT, it has never been a PVD. And so it's one of those things. I don't know why, frankly. In our EPIC interpretation, we wrote PVD because now the fellows click it, or the residents click it, and it's like if you see it, it wasn't submitted. But it's I mean 100%. I've never seen the hyaloid on the OCT and then gotten into the OR and detached.
I'd say by definition, you don't have a PVD if you see it on those.
Well, but that's what was interesting about Ed's paper that you mentioned, is that it had to be detached, but it could be visible, but it had to be detached on all 31 rasters. My comment, and one other comment and then question to you, the other thing I've found, and we don't often have the luxury with our RD patients, but occasionally we do, I will also look backwards. Because occasionally it's really hard. It's easy to see if it's there, but it's also hard to know, is it not there? And if you go back 6 months, if you have the OCT, then all of a sudden you see, oh, it's very clearly a PVD, and use this also for acute PVD where you're not sure they have weird symptoms. Yeah. That can actually be really helpful too. The question to you that I don't do is you had the optic nerve, a macular scan over the optic nerve. Do you standard direct the photographers to do that in your RDs? When do you get that scan? And is it done on a regular basis?
Yeah, great question. There was a time when I first started that I tried to get on everyone. I made a 21 HD line protocol, but obviously we all, it's hard to change like a practice pattern. So in the text, there's so many of us, so it's hard for them to know exactly, oh yeah, this Dr. Mammo's patient will do it. So now if I know what RD referral is coming in, my tech knows to get that.
And specifically order it.
Yeah, but if it's like a random one, I'm usually not having it. But in my ideal world, actually, that would be like my main OCT that I would get.
Yeah, and I mean, I think it's a great learning opportunity because, again, going back to what I was saying, I think OCT is amazing, but we don't often get that macular-based raster over the nerve. And I think if there's a question, it's a really good thing to add. Alexandra, I loved your talk. One of the things I will say where I found it most useful isn't always in the most complex pathology. It's when I don't know what I'm looking at. And a lot of times with depression, you'll look and you'll say, is that fluid or is it, cystic degeneration? Is it early schisis? Have you used it under depression and other times when you've used it out in the periphery as well?
Yeah, I think it's a fantastic question. I had a patient that had macular pathology, and you generate the PVD, and things look funny in the periphery, and you're like, did we have a problem? And imaging it just showed that there was a schisis cavity, just a standard schisis cavity that didn't need any treatment. So I think that can be reassuring. I would say the question I get a lot about periphery is like, oh, do I have a special person who knows how to do the intra-op OCT? And I will tell you, it's whoever is the circulating nurse, and they have usually actually no idea what they're doing, because that's not in their responsibilities. And you can it doesn't take a lot of time. You just position it, and then they click a button, and they can kind of find the layers. So I think it's very doable. And the other one pathology that I like it in that is very, very common is VMT. Because I think if you release the VMT and you didn't create any hole, you're done. You don't need to peel, in my opinion. You don't need to put the gas bubble. It's really very different surgery than if you're going to peel and then you're going to put, I don't know, SF6 or something. So that's a very simple bread and butter case that I use it in.
Yeah, are you using it in every case?
No, not at all. Not at all.
Yeah. What percentage would you say?
I think it's a very small percentage, but I always try to think, is it going to change my surgical management? I think, a lot of work that Justice has done, like even talking about, finding the fluid under PFO. I think it's very interesting from mechanistic standpoint, but you're going to still do the same steps. So I only utilize it when I think it's going to change what I do.
And I would say one of the things that you find is you don't know when it's going to change it in probably more than 80% until you're in there. Right. And you're identifying, like you mentioned, the VMT cases. And as you're elevating the retina, you're seeing retinal elevation as you're going further out and asking, the fellow to not pull as much. And then you can go and look with the OCT and see there's no break. You don't have to do anything else with it as well.
And I think it's interesting what Danny was talking about. I think the vitreoretinal interface in periphery is very interesting pre-op, and I think we know very little about it. We just think that it's all the same for all these patients, and it's not.
Out of curiosity, I thought those schisis detachment cases were so cool. And, we were talking, I was like, the way you did those surgeries is so elegant. Like, I basically just find the area of retinal detachment, like make a retinotomy, drain, and then laser the entirety of the schisis cavity. And I thought the way that you did it was just so much more elegant than that. How long does it take you to actually find the inner break? Like when you're kind of sort of scanning through, especially when it's not like clinically obvious?
Yeah, I think it depends. It's usually somewhere in the area next to the outer retinal defect. So it kind of guides you. There is an argument, most people kind of say, well, it's schisis, it's a blind spot, right? I'm just going to drain. But I think it's very interesting because I actually think that not all schisis is created equal, because sometimes you drain and you're looking in. You have a full thickness defect and nothing is happening. Mm-hmm. So I think there's more to learn about that in those cases. Of course, I showed the ones that look beautiful, but either intrinsic stiffening, is there something else that's there? I think it remains to be seen.
Yeah, beautiful case.
Excellent. Thank you so much.
Yep. Thank you, everyone. Thanks for everyone for sticking around. That was fantastic.
Any questions from any of the attendees or the fellows? We appreciate you all coming. For the fellows, I assume you guys probably want to enjoy Montreal. So we're free for you guys to come up and ask us any questions if you'd like, personally for sure. But we're going to conclude now instead of the fellows panel. Thank you guys so much.